دكتور نبيل، أي وقت وتبدأ اتفضل.
السلام عليكم ورحمة الله وبركاته. مرحبا بكم في رحاب المستشفى السعودي الألماني بالرياض، حيث نستأنف فعاليات مؤتمر طب الأطفال وحديثي الولادة السابع، اليوم الثالث والختامي. ندعو الله أن يكون يوما موفقا وأن يعود بالنفع على الجميع. Now we'll start our first session. Our first speaker will be Dr. Saeed Al-Ghuwairi. Dr. Saeed Al-Ghuwairi is a senior consultant pediatric nephrology in Saudi German Hospital Riyadh, and previously he is head of the pediatric nephrology division in Prince Sultan Military Hospital in Riyadh. Dr. Saeed will give us a talk about approach to a child with hematuria or red urine. Welcome, Dr. Saeed, and thank you for being with us. I will share your presentation, then you can start.
Assalamu alaikum wa rahmatullahi wa barakatuh. I'd like to thank the organized committee for their efforts to continue this symposium for the last 7 years. My talk today will be approach to the child with hematuria. Hematuria is the most common sign of urinary tract and renal disease. I'll start by to go through the introduction, definition, pathophysiology, workup, and approach. Approach to the child with hematuria. Red urine is either hemoglobinuria. When we have the hemoglobin too high in the blood vessels, will appear in the urine. And myoglobinuria, when we have myoglobin in the urine, we'll call it myoglobinuria. Can be drugs like rifampicin can cause red urine, or food beta or food coloring, or urate crystals can cause this red urine. As I said, hematuria is a very common presentation in children. It can be macroscopic gross hematuria or frank hematuria, or microscopic. Microscopic can be isolated or associated with other symptoms and clinical presentation. The first alert that trigger extensive workup is related to serious urinary tract disease, like, for example, rapid progressive glomerulonephritis, where they presented with gross hematuria and kidney injury, proteinuria, hypertension. That we have to do immediate investigation and management. Or it can be benign and cause not harm. As a definition of macroscopic hematuria is visible to the naked eye and confirmed by microscopy. A clothes or cola-colored urine. Microscopic hematuria is dipstick test during a routine examination or workup for any reason. The sensitivity and specificity is high to find 1 to 5 RBCs per high bore field. If we have more than 5 to 10 RBCs per high bore field in more than 2 occasions, we have to consider as significant. And hematuria in urinary stream can be at the beginning urethral causes like urethritis, or through it like renal causes, either pyelonephritis or renal stone or cancer, or terminal bladder causes like cystitis. The pathophysiology, glomerular RBCs cross the glomerular basement membrane through structural discontinuity in the capillary wall. Dysmorphic RBCs may be associated with proteinuria, thus we will have to send urine for RBCs morphology to see the dysmorphic RBCs. Can be tubular interstitial, like direct injury will leads to ischemia, or renal papillary necrosis, or vascular malformation like AV fistula. Urinary tract infection like pyelonephritis or cystitis, clots, bright red, non-dysmorphic, stones, or exercise. Recurrent gross hematuria can be IgA nephropathy. IgA is unknown cause, genetic or environmental. The presentation will be recurrent gross hematuria during or 2 to 3 days after upper respiratory tract infection, or benign familial hematuria, or Albert syndrome. Albert syndrome is a genetic. There is family history of the disease, and there is history of hearing and vision deficit. Acute glomerulonephritis, all type of glomerulonephritis can be there, including plus Hersheyline Berbera. Or rapid progressive glomerulonephritis, and this is very important and urgent for immediate investigation and management. We have to do like ANCA, to investigate for ANCA and SLE and glomerulonephritis. Types of acute glomerulonephritis. Acute glomerulonephritis can be with low complements, like post-infectious glomerulonephritis, like post-streptococcal glomerulonephritis, when they presented with cola-colored urine. And some of the cases presented either with protein plus associated with proteinuria, hypertension, or renal impairment. The prognosis is excellent because the renal impairment will resolve, hypertension will resolve within a few weeks, and proteinuria will resolve in 3 to 4 months. Again, the cola-colored urine will be clear in 7 to 10 days. Or membranoproliferative or SLE. SLE, skin rash, and renal involvement, which we will there is proteinuria. Non-complements, that mean normal complements, IgA nephropathy, as mentioned before, membranous glomerulonephritis, Hersheyline-Berbera when they presented with hematuria, either microscopic or gross hematuria, and abdominal pain, joints pain, and proteinuria. Albert syndrome, as mentioned before, ANCA vasculitis. Hematuria and tubular interstitial, acute pyelonephritis, or acute interstitial nephritis. Acute pyelonephritis will be presented with very high temperature, low in pain and tenderness, and acute interstitial nephritis will be presented with hematuria and acute kidney injury, or TB. Hematologic causes of a tubular is sickle cell disease. They have biliary necrosis, coagulopathy, renal vein thrombosis, thrombocytopenia, or infective endocarditis. Urinary tract, and this is the most important because the most common cause of this hematuria is urinary tract infection. So infection, either bacterial or viral, nephrolithasis, hypercalciuria, when we send urine for calcium creatinine ratio will be high. Structure anomalies, congenital anomalies like hydronephrosis, or autosomal recessive or autosomal dominant polycystic kidney disease. Can be secondary to trauma, can be secondary to tumors, heavy exercise, or medications like aminoglycosides, aspirin, or cyclophosphamide. What's the workup? We'll do urine analysis to look for blood and protein, and if there is any bus cells or high white blood cells to indicate, or nitrate to indicate urinary tract infection. We'll send random urine for protein creatinine ratio, CBC, renal profile, serum albumin, complement C3, ASO, and ANE, ANCA, and renal biopsy. Workup for macroscopic hematuria, not glomerulonephritis, imaging, will do CT and management with a trauma service. Or UTI, urine culture, treat according to the sensitivity, and we will do ultrasound. Stone, there is family history and ultrasound obstructing stone or mass, refer to the urology and surgery. and stone workup, and urine culture. The workup for isolated asymptomatic microscopic hematuria: repeat 2 times without exercise in 6 months. That means urine analysis, have to repeat it. And parents will investigate the parents with the history of stones, and we'll do, if there is history of stones, we have to do stone workup as a metabolic screen and ultrasound. Investigation, we will do ultrasound, hemoglobin electrophoresis, and hearing test, especially in the Albert syndrome. The workup for microscopic hematuria is CAS and proteinuria, complement serology, family history of progressive glomerulorenal disease, will do complement serology, hearing and vision test, other family member findings, and genetic counseling. And investigation will do ultrasound and kidney biopsy. The workup for microscopic hematuria, complements, and serology, hearing test, and ultrasound and renal biopsy. And conclusion, the hematuria is the most common sign of urinary tract and renal disease. Hematuria is the most common cause of hematuria is urinary tract infection. Rapid progressive glomerulonephritis needs immediate investigation and management. Persistent microscopic hematuria needs regular follow-up. Thank you.
Thank you so much, Said, for the excellent presentation. I will see if there is some questions. Oh, no. Okay. So our next speaker will be Dr. Amin Al-Muteri. Dr. Amin Al-Muteri is a consultant neonatology in King Saud Medical City Al-Shmaisi Hospital in Riyadh. Dr. Amin will give us a presentation about golden hour for neonates. أهلا دكتور أمين، وسعداء بمشاركة حضرتك، وحضرتك تقدر تشير البرزنتيشن.
السلام عليكم.
عليكم السلام ورحمة الله وبركاته. واضحة الصورة تمام. توكل على الله.
يعطيك العافية دكتور نبيل على الاستضافة.
تكريم.
بسم الله الرحمن الرحيم. I will talk today about the NICU golden hour. بسم الله الرحمن الرحيم. I will talk today about the NICU golden hour. The golden hour concept borrowed from the trauma care. Admin Cowley, the father of trauma medicine, was first introduced in neonatology, adapted from adult trauma literature by Reynolds in 2009. This concept includes evidence-based medicine, evidence-based intervention during the first 60 minutes of postnatal life to better support to the fetal to neonatal transition, leading to better short and long term outcome. The first hour of the life for a neonate represent a time period during the which infant face challenge, risk for short and long-term injury, lifelong developmental delay, and even the possibility of the death. The short-term outcome, hypothermia, hypoglycemia, respiratory compromise, sepsis, risk factor for intraventricular hemorrhage may be decreased as well. The long-term outcome, epilepsy, developmental delay, cerebral palsy, vision and hearing loss. The evidence for golden hour, the first report by Reynolds in 2009, the decreased incidence of ROP and chronic lung disease, significant improvement in the time to surfactant administration time to administration of dextrose amino acid, and increase admission temperature. In 2014, Castro did a significant increase admission temperature, 36.5 to 37.4, admission glucose more than 50, and number of infants who receive IV fluid within 1 hour. Later in 2014, the faster time to umbilical place, time to reach NICU, and decrease in intraventricular hemorrhage didn't report the difference in the minimum temperature, PPD, incidence, or length of stay. Lambeth in 2016, significant decrease in the time to start of IV fluid and antibiotic, trend toward surfactant administration in the first 2 hours. Probe in 2020, improvement in hypothermia and minute to completion of stabilization. The lag in 2021, QR interval in the level 4 in ICU, goal of decrease chronic lung disease rate. The rate decreased from 33.5 to 16.5 following several interventions, include golden hour, gestational age, based delivery room protocol that encourage early surfactant administration and timely extubation. To get the better outcome for need evidence-based intervention. In this picture, is all what you need to do it in the first hour. Need antenatal counseling, ask the mother to receive steroid or not, magnesium sulfate, a team briefing, and delay cord clamping after delivery for 30 to 60 seconds, follow NRB guideline, prevent hypothermia, and any patient with prenatal depression and need cooling need to start cooling as soon as possible, need to give the patient cardiovascular support to maintain blood pressure and perfusion, give respiratory support, start resuscitation for term baby within 21%, and preterm with, started with 21 to 30%, following target saturation, early CPAP in the labor room, early Serfanta and caffeine, gentle ventilation support, allow permissive hypercapnia, and early extubation. I'll also need to give nutrition support by inserting line, TBN, encourage breastfeed, and prevent hypoglycemia. Also need to prevent infection, need to send lab within 1 hour, also need to update the family. The evidence for a golden hour to improve outcome, there is a need in a pre-delivery planning and counseling, delivery room management, and resuscitation. I will speak also brief on the hypothermia and hypoglycemia. Team approach, team and other mean team working together. Need effective communication with OB/GYN and anesthesia team, also with RT and nurse, and other doctor work with us. Standardize many things of protocol, checklist, and skill development stimulation. Essential stage to care for the golden hour, need to preparation before birth, care at delivery, and management, manage transport and care in the neonatal unit. Pre-delivery planning, antenatal counseling, first introduced in the neonatal station program in the 2015, is critical prior to extreme preterm and extreme low birth weight infant delivery. The team leader should be met with parent and counsel them about the outcome, potential short-term and long-term complication related to extreme prematurity, and anticipate the NICU course. Antenatal counseling can reduce prenatal anxiety and stress and increase satisfaction. I will talk now about the golden hour step. And first step in the delivery room management. most important to do delay cord clamping. In 2015, the NRB guideline began to recommend to delay cord clamping after 30 to 60 seconds for all premature infants who don't require immediate resuscitation. The report benefit for delay cord clamping for term baby, high hemoglobin at 4 to 12 months, improve serum ferritin during the first year, improve total body iron store at the 1 year of age. For a benefit for prematurity, higher circulation blood volume for 24 to 48 hours, fewer blood transfusion, better systemic blood pressure, and reduce need to inotropic support. Need also follow the NRB guideline, and most important for protocol for NRB, initial step, initiation for initial respiratory assessment and heart rate, indication for BBV, same, and possible role for CPAP. Step 2, hypothermia. Why the hypothermia most important? Because this is common in the neonate because the large body surface area and very large head compared to the body and decreased subcutaneous fat. The recommendation for delivery room temperature at least 23 to 25 degree. Polyethylene bag recommendation to less than 28 weeker. Thermal matrix recommendation to less than 32 weeker. Heated humidified gas improve normothermic in 2 study in both less than 28 and another study less than 30. Pre-warmer incubator. The type of heating loss in the baby by radiation, evaporation, conductive, and convection. Hypothermia. Report incidence in very low birth weight newborn is 31 to 78%. After birth, the wet newborn may lose enough heat to decrease the body temperature by 2 to 4 degrees, and with most heated loss in the first 10 to 20 minutes unless appropriate measures are taken. The development of hypothermia contributed to respiratory distress, hypoxemia, metabolic acidosis, and impaired coagulation. Studies show that temperature less than 36 in the preterm infant was independently associated with increased likelihood of IVH, respiratory distress, hypoglycemic, and late onset sepsis. Lab-tox conduct, the admission temperature was inversely related to the mortality. 28% increase in the mortality per 1 degree decrease in the temperature. The chance of early neonatal death was 1.64-fold higher in the infant with admission temperature less than 36. Step 3, monitoring saturation and a pulse oximeter. Need to follow the target saturation after birth in 1 minute 60 to 65, and in 5 minutes 80 to 85, and 10 minutes 85 to 95. Step 4, golden hour. Intubate the baby if respiratory distress with severe distress or apnea by most expert person in the team. Step 5, transport the baby to the NICU as soon as possible. Step 6, after arriving to the NICU, place the baby in the incubator, obtain oxygen, obtain auxiliary temperature, blood sugar, and obtain head circumference and weight and length. I will talk now brief about the blood sugar. Hypoglycemia, the common problem in the neonate in the NICU, around 23 to 50%, more in the preterm, 1.3 to 4.4 per 1,000 for full term, and 15 to 55 per 1,000 for preterm. There is association between hypoglycemia and neurodevelopmental outcome. our goal to continuous glucose infusion rate of 6 to 8, limited IV fluid interruption to avoid fluctuation on the blood blood glucose level. Step 7, enter the medical management order, include IV fluid, antibiotic, and lab request. Step 8, insert UVC and UAC if indicated by physician, and if not indicated, we can insert peripheral line by bedside nurse. Step 9, X-ray should be done immediately after inserted central line to confirm the position. The step 10 of golden hour, initiate starter vanilla TBN. Step 11, initiate for antibiotic as ampicillin and gentamicin from floor stock in the NICU. Step 12, perform physical exam. Step 13, update the parent and counseling them about the breastfeeding. Father should visit the baby at 1 hour of the age. This is example for golden hour checklist. And this is the timeline for golden hour. As we know, we're working together, RT and nurse and resident and the senior doctor, and need time to working together. Take-home message: strong communication, teamwork, evidence-based, best practice strategy, good clinical sense. Thank you.
Thank you so much, Dr. Amin, for your nice presentation. Now, just wait, I will see if there is someone who don't have any questions. So we'll shift. Our next speaker will be Dr. Haider Samori. Dr. Haider is a senior consultant in ICU neonatologist in the Saudi Medical City, and he is the previous head of the NICU in Al-Shimisi Hospital. Shimisi Hospital is one of the biggest maternity hospital in Riyadh, and consultants from Al-Shimisi and Al-Yamama hospitals here are the pioneers in ICU. So Dr. Haider will speak to us about polycythemia in newborn. Thank you, Dr. Haider, for being with us, and you can start your presentation.
Thank you, Dr. Nabil, for giving me this chance to take in this excellent annual webinar. My talk today is about polycythemia in the newborn. Okay, this is the outline of my talk. First, polycythemia, as you know, it is an abnormal elevation of the circulating RBCs mass, and it is seen frequently in our newborns. This abnormal increase in hematocrit increase the risk of hyperviscosity, microcirculatory hypoperfusion, and this will lead to multi-system organ dysfunction. Before we define the polycythemia, we have to know the incidence of this polycythemia. It is common in term baby. So before we define it, we have to know the normal hemoglobin and the hematocrit in a term baby at birth. The hematocrit usually in the term babies around 50% plus minus 7%, and the hemoglobin concentration is around 16 gram per deciliter plus minus 2 gram. So if we define the polycythemia, we'll define it as a newborn, as a venous hematocrit more than 65%. And later I will speak about why we are choosing the venous sample. Or a hemoglobin value more than 22 gram per deciliter. So its incidence around 1.5 to 6% of all alive births. It is higher among the babies who are small for gestational age, large for gestational age, and also in the mothers who's living in a high altitude area like Abha and Al-Baha in our country, I mean. Less likely to occur in a premature babies less than 34 weeks. So when we measure the value of hematocrit, the measured value for hematocrit and viscosity are affected by a number of factors. The first factor is the source of blood. Is it capillary sample? Is it peripheral vein? Or it is umbilical vein? The capillary sample will be 10 to 15% higher than umbilical vein in the hematocrit measurement due to stasis of the blood and the cold extremities. So if we want to take a sample of hematocrit from the capillary area or from the heel of the feet, we have to make sure that it is warm enough and the flow of the blood is fine to conclude about it. If we take it from the peripheral, it is less by 5%, less than the capillary, and the more accurate will be in the umbilical vein because of the good flow of the blood. Second factor is the age of the infant at the time of measurement. As you can see in this diagram here, the hematocrit will peak around 2 to 6 hours of age. So if we'll take it early after the birth immediately, it will not give us conclusion about the maximum hematocrit we can get it in the babies. So if the baby is at high risk of polycythemia, so the best time to take it after 2 hours of age up to 6 hours, and usually we are taking it at 2 hours of age. The third factor is the methodology of processing the blood. Is it an automatized analysis in which the hematocrit value is indirectly calculated from the hemoglobin and the mean corpuscular volume in the automatic blood analyzer? Or the other method is if we take it from the microcentrifuge method, in which plasma is separated and the backed are volume measure to give the hematocrit. The automatized one will give us the lower values. We'll talk about the pathophysiology of polycythemia. The cause usually is multifactorial, but most of the patient will be classified as having active or passive. Active, that means increased fetal erythropoiesis, or passive, that means increase the volume of the blood and erythrocyte transfusion to the baby. In this table, we can discuss the common condition associated with the neonatal polycythemia. So if we take it from the antenatal factors, increased fetal erythropoiesis in patient whose mother is having preeclampsia or maternal chronic hypertension or abruptio, or the mother who's having cyanotic congenital heart disease or maternal smoking or heavy alcohol smoke. This will lead to placental insufficiency, I mean chronic hypoxia. This hypoxia will affect the supply of blood to the kidneys, and directly with this will lead to increase the fetal erythropoietin and stimulation of the bone marrow to secrete more RBCs. Second factor antenatally is the endocrine abnormalities, such as congenital thyrotoxicosis or maternal diabetes with poor glycemic control. Also, the genetic disorders such as trisomies and big with Wiedemann syndrome. The cause of the genetic disorder to cause this polycythemia is not clear, and they found trisomy 21 is more common than trisomy 13 and 18. The explanation may be due to that the trisomy 13 and 18 will aborted initially or early, or most of them will be DNR and they will not resuscitate them at birth. The cause why they will have polycythemia, it is also unknown, but in some studies they found the concentration of cord erythropoietin in such cases, especially Down syndrome, will be high, indicating that maybe they are exposed to hypoxia in utero. During delivery, or immediately after delivery, 20-20 transfusion is one of the causes that increase the volume of blood, and in monochorionic pregnancy it will happen. Also, the placental fetal transfusion with a delayed cord clamping, and as you know, the NRB recommendation now it is from 30 to 60 minutes. Seconds, sorry, from 30 to 60 seconds. And I think this is the best, as the NRB described, it will prevent later transfusion, and it will control the blood pressure and decrease the IVH in the prematures also. Also, prenatal asphyxia, or I mean acute asphyxia and oxytocin administration, as you can see here, in the acute asphyxia, in acute fetal distress and peripartum hypoxia, transcapillary leakage of plasma will occur, and shifting the blood from the placenta to the fetus is increased, and the result of that is an increase in plasma volume and erythrocyte mass in the fetus. Philip and his colleague examined the placenta residual volume and neonatal outcomes. They found the fetal distress and low Apgar score were associated with lower residual volume. There is also a correlation between the duration of hypoxia and the volume of blood shifted into the compartment. If the prolonged hypoxia, that means the volume will be shifted to baby is more. The oxytocin administration to the mother also can increase the volume of placental transfusion to the newborn. We'll go back to the same slide. There is some studies regarding the chronic hypoxia in the babies. They found the risk of polycythemia was 12 times greater in the appropriate for gestational age, whose mother is hypertensive, if we compare it to the non-hypertensive mothers. Also, the cord blood hemoglobin and hematocrit were significantly higher in the infant born to the smoking mothers, 55% if we compare it to the non-smoking mothers. Also, if we see the effect of the diabetic mothers on the babies to have a polycythemia, the prevalence of polycythemia in infants whose mother was diabetic was 13.3%, which is significantly higher than that in controls, only around 5%. Delayed cord clamping allows the delivery for delivery is increase the volume of blood to the infants. If we prolong it more than 3 minutes, the blood volume may increase by 30% if you compare to the neonate with early clamping within 30 seconds. That's why the recommendation now of the NRB from 30 to 60 seconds. Also, there are some studies before the recommendation of the NRB. Hutton and his colleague, they collected data and analyzed it from 7 randomized studies and showed neonate in a late clamping more than 3 minutes had a higher incidence of asymptomatic polycythemia with a benign course. However, more recent meta-analysis showed that delayed cord clamping more than 30 seconds didn't cause any clinically significant change in hematocrit at 1 and 4 hours of age, which is the peak of the hematocrit after delivery. So, what is the relation between polycythemia and hyperviscosity? Viscosity is referred to the thickness of fluid and is a measure of the fluid internal resistance to flow. It rises linearly initially with the hematocrit reaching 60 to 65, but after that it will increase dramatically if the hematocrit more than 70. As you can see it in this diagram, you can see the relation will be linear till the 60%, then after that it will increase dramatically. When we reach more than 70, it will go up. So, because the resistance is affected by viscosity as well as the caliber of the blood vessels, the effects of polycythemia on the blood flow patterns usually most pronounced in the microcirculation. Hyperviscosity also indirectly it can reduce the pulmonary blood flow directly, this will lead indirectly to cause systemic hypoxemia. Also, the change in the blood flow may also alter the delivery of the substrates like glucose to the organs that are dependent on the plasma flow like brain. The clinical findings of the polycythemia, it can result in a wide range of symptoms involving several organ systems, but plethora is not considered as a symptom. So if we are saying our baby is only plethoric, this is the only feature of polycythemia, but it is not considered one of the symptoms. I can depend on that to treat. Most of the newborns, around 80 to 90%, they will be asymptomatic, and the symptoms which lead to need treatment, it will be in a few around in 10% of the cases. The most patients who have polycythemia remain asymptomatic. The clinical feature may be recognized as early as 1 to 2 hours after birth. And this is the peak of the hematocrit with a normal postnatal fluid shifts from intravascular to extravascular. In some babies who have a high portal hematocrit, the symptoms may be delayed until the 2nd to 3rd day postnatal day, when the excessive depletion of the extracellular fluids may be lead to hemoconcentration and hyperviscosity. But if the baby remain asymptomatic within 48 hours to 72 hours of age, that means he will remain asymptomatic and safely you can discharge your baby. In this diagram, this summarizes the clinical features of the hyperviscosity and polycythemia. As you can see, we started by the CNS. Usually the CNS symptoms will be few, but it is serious, like seizures or stroke. And the seizure, it can happen only in 1% of the cases with symptomatic, and the stroke, it is in a very, very, very rare cases. What's the most common is the metabolism or the manifestation of hypoglycemia, jaundice, and hypocalcemia. So the hypoglycemia, it can reach in up to 40% of the cases due to increased consumption of the glucose or decrease the gluconeogenesis. Or if the cause of this polycythemia is infant of diabetic mother, there is another factor like low hyperinsulinism. The increase of the volume of the RBCs, this will lead to jaundice because the lifespan of these RBCs will be shorter than the adult RBC. Also, hypocalcemia, it can present in up to 10% of the cases due to calcitonin gene receptor, it will be high. This will lead to hypocalcemia, or if it is a part of manifestation of infant of diabetic syndrome. The heart, lungs, some patients will have tachypnea, tachycardia, respiratory distress, cyanosis, and if we will do echo or chest radiography, maybe that will manifest by cardiomegaly, sometimes with pulmonary plethora, and echo will show the increased pulmonary resistance and pulmonary hypertension. Gastrointestinal tract, some babies, they will show manifestation of poor sucking, feeding intolerance in up to 20% of the cases, but necrotizing enterocolitis will be low, and the percentage almost 1 to 2% of the cases. And also this necrotizing enterocolitis, it can be increased if we are inserting UVC or if we are doing exchange transfusion with fresh frozen plasma, as we see later in the treatment of polycythemia. Kidney manifestation, like oliguria, it is depending on the blood flow. Sometimes with the renal vein thrombosis, it can be affected. But don't forget dehydration also, especially in the cases who's coming to ER as outborn, maybe they will be, their polycythemic cause will be dehydration. mild thrombocytopenia. It can present due to consumption. And also part of the cause, like an infant with diabetic mother or genetic disorder like Down syndrome, they will have some thrombocytopenic changes. Don't forget about low peripheral gangrene. It can happen if it is severely polycythemic baby. Whom you will screen? If there is risk factors, as I mentioned, and there is some manifestation, so any patient who's small for gestational age, he should be screened for polycythemia, infant of diabetic mothers, large for gestational age, monochorionic twin, especially in the larger twins, or dysmorphic features like trisomies. The time for screening, around 2 hours of age, and you can delay it up to 4 hour age. This is the maximum or the time of the peak of the hematocrit. Hematocrit less than 65% at 2 hours of age doesn't need any further investigation unless the patient will be symptomatic. If we found at the hour of age the hematocrit value more than 65%, this and baby remain asymptomatic, this will lead follow-up screening at 24 hours, 12 hours and 24 hours of age. Regarding treatment, controversial because the lack of evidence showing the cut number to treat the patient, and also the long-term outcomes didn't support this strategy. Before we start or think about treatment, you have to exclude the dehydration by weighing the baby, especially the patient who is coming to your ER from home or from other hospital, to exclude dehydration. If dehydration is present, it should be corrected by increasing fluid intake. Hematocrit will be, as we mentioned, will be reassessed frequently. Also, plasma glucose, bilirubin, and cardiopulmonary status should be monitored. If the hematocrit decrease or remain stable and the patient remain asymptomatic, monitoring continued for 24 to 48 hours. Then after that, we can discharge the baby. Regarding the method to treat, there is 2 methods. The first one is conservative management with hydration. This will reserve it for a symptomatic patient with the hematocrit usually from 70 to 75% by increasing the fluid or daily requirement fluid either through orally or IV by 20 to 30 ml per kg. This will cause hemodilatation and resultant in decrease in the viscosity. Also, if we add fluids by D10%, this also will prevent the hypoglycemia to happen in this baby. But be careful increasing fluids in the prematures. But polycythemia in premature, as we mentioned earlier, it will not be a common problems, which is partial exchange transfusion. The indication for it is the presence of symptoms suggestive of polycythemia and hyperviscosity, as we mentioned in the clinical findings, or if hematocrit is more than 75% in an asymptomatic infant. Our aim from partial exchange transfusion is to decrease the hematocrit to the target cell volume of 55%. Following partial exchange transfusion, the symptoms like tetanus may persist for 1 or 2 days. How much fluid we want to do it? In this formula, as you can see, the blood volume of the baby, we can estimate it by 80 to 90 ml per kg in a term babies and 90 to 100 ml in a preterm babies. And also in the small for gestational age, we can increase this volume up to 100 to 110 ml per kg. Or by using this nomogram, which published early in 1982, as you can see here down, the birth weight ranging from 1,000 up to 5,000. And here is the blood volume. If you can see it here, by increasing the weight, the volume is decreased. example of that, if we'll take 3 kg, the volume we can see around 88 ml. If we will go to the lower weight, like 1.5 kg, the baby, we need more than 100 ml. So we'll multiply the volume per kg, multiply it by the difference between the observed hematocrit. Observed hematocrit is the measured or the hematocrit you found in the CBC, minus the desired hematocrit, which we said we need it from 55 up to 60%. This will be divided by the observed hematocrit. So which fluid, which type of fluids? We have crystalloids and colloids. Crystalloid like normal saline or Ringer lactate, and colloid like fresh frozen plasma and albumin. Crystalloid are preferred for many reasons. The first one is it is lower cost, easily available in each unit. It produces similar reduction in hematocrit as colloids, and don't carry risk of transfusion-associated infection like viral infection. It can be transmitted by fresh frozen plasma. In this systemic review done by Dr. Diwal and his colleague, which was published in 2006, they reviewed studies regarding types of fluids they are using, and their conclusion, they found their results. 6 studies with a total of 235 newborns match the inclusion criteria. When comparing crystalloid and colloid replacement solution, there was a clinically an important difference in hematocrit, and also their conclusion, there is a little difference in effect between the plasma 5% albumin crystalloid solution. Since normal saline is cheap, available all the time, and doesn't carry risk of transfusion-associated infection, so the recommendation normal saline is the optimal dilutional fluid for exchange transfusion in polycythemic neonates. Adult plasma has been shown to increase the blood viscosity when mixed with fetal erythrocytes. That's why one of the risk factors for necrotizing enterocolitis in neonates, either term or premature, is the transfusion, either fresh frozen plasma or packed RBCs, which increase the viscosity. In a study conducted by Black and his colleague, the use of fresh frozen plasma was associated with high incidence of necrotizing enterocolitis. That's why normal saline is superior to fresh frozen plasma. The technique, either to use peripheral or umbilical route. The first one is the umbilical venous exchange, which is the most commonly used in the NICUs. By a simple procedure, push and pull technique. If there is a difficulty to use it, you can use umbilical venous for removing of blood and using the peripheral line to give fluids. If there is any contraindication like onpholitis or inability to connect the umbilical vein or other GIT disorder like necrotizing enterocolitis, peripheral venous exchange can be done, but it requires expertise and ability to perform cut down. How to perform it? After inserting the line, in clinical practice, the exchange usually is performed in steps of 5 to 10 ml, but we prefer 5 ml better. During this procedure, you have to keep attention to the thermoregulation, glucose hemostasis, and vital signs. And the resuscitation equipment should be ready, and also the IV dextrose and medication should be also ready. The following exchange transfusion, feeding should be withheld for 2 to 4 hours. Clinical studies reveal some measurable benefits following partial exchange transfusion, like heart rate, left ventricle stroke volume, systemic oxygen transport, were all increase after partial exchange transfusion. In another report, The researchers have documented improvement in the left ventricle function, decrease in pulmonary and peripheral vascular resistance, and improved cerebral and mesenteric blood flow in infants treated with partial exchange. But like any other procedures, partial exchange transfusion carry risk to the baby, like vessel perforation or vasospasm, thrombosis, arrhythmia, infection, bleeding, necrotizing tuberculitis, and eventually death. A recent systemic review published in 2010 in a Cochrane database shown that the partial exchange transfusion through the umbilical route may be associated with increased risk of necrotizing enterocolitis. The long-term outcome with polycythemia after partial exchange transfusion, there is very little data to suggest that partial exchange transfusion improves the long-term outcome in patients with polycythemia. At early of 80s, studies started to see the effect of polycythemia in the newborn and also the effect of the partial exchange transfusion in the outcome. Studies by Black and his colleague, the number was 93 babies, and also in the Goldberg and his colleague, number of the neonates was involved, 20 babies, failed to demonstrate any improvement in long-term outcome with the use of exchange transfusion. Bada and et al. Number of the babies included in that study is 49 babies, have failed also to show any beneficial effect on long-term outcome with partial exchange transfusion in neonates with asymptomatic polycythemia. Studies continued to be done after that, and in 2006, Dempsey and his colleague, they studies or they did systemic review about short and long-term outcome following partial exchange transfusion in polycythemic newborn. And their conclusion, there is no evidence of long-term benefit from partial exchange transfusion in polycythemic infant. And the incidence of GIT injury is increased. The long-term outcome is more likely to be related to the underlying cause of polycythemia. Also, the Cochrane Library, they conclude in 2010, there is no proven clinically significant short-term or long-term benefit of partial exchange transfusion in polycythemic newborn who were clinically well or who have minor symptoms related to hyperviscosity. It may lead to increase in the risk of necrotizing enterocolitis. So, with all these systemic reviews, Shishmil and his colleague made the following recommendation in 2004. In asymptomatic infant with presumed normal or increased blood volume, monitoring is sufficient. In symptomatic patient with a hematocrit more than 65%, partial exchange transfusion with normal saline should be used to reduce the ongoing tissue damage. In patients with reduced blood or plasma status like IgR, infant treatment should be with early feeding or plasma expansion with IV fluids. Consider partial exchange transfusion in asymptomatic infant with presumed normal plasma and blood volume only if repeated measurement reveal a venous hematocrit more than 75%. So we can summarize what we are talking about it in capillary hematocrit. If the baby is having more than 65%, then we'll confirm with a venous hematocrit to make sure that the patient is having polycythemia. Then exclude dehydration. If baby is symptomatic, we'll do partial exchange transfusion, especially if more than 70%. If baby is symptomatic, we'll divide into two groups. If hematocrit ranging from 65 to 70%, we'll monitor the baby. From 70 to 75%, we'll consider hydration by increasing IV fluids for this patient by 20 to 30 ml per kg. If more than 75%, we'll do partial exchange transfusion. So, in conclusion, neonatal polycythemia defined as venous hematocrit more than 65%, and it is a common problem in newborn, infant, born, post-term, or small for gestational age of infants of diabetic mothers, 20/20 transfusion, especially the recipient, and those who have chromosomal abnormalities like trisomy 21 are at higher risk. Also, the cause is multifactorial, but we can classify it as active by increasing the fetal erythropoiesis, or by passive by increasing the erythrocyte transfusion. By increasing blood viscosity, polycythemia can impair microcirculatory flow in end organs and can present with neurologic, cardiopulmonary, or GIT or metabolic symptoms. Partial exchange transfusion is the recommended treatment for symptoms, and crystalloids as effective as colloids, and there is no clear long-term neurological benefits from partial exchange transfusion. It's the end of my talk, and if you have any questions.
Thank you so much, Dr. Haidar, for your great presentation. I really enjoyed it, and you talked about 15 minutes more, so you prepare the dinner. I will come to you after the...
I'm ready, Dr. Nabil, because I took this 15 minutes from Dr. Saeed and from Dr.
I know this, I know. I know. Okay, thank you so much. Allah, it was a great lecture, and you are always great. Yeah, like,
thank you, Dr. Nabil. Thank you so much.
Was awesome. Now we got a confirmation that Professor Dr. Dina Volker from USA Mayo Clinic will be with us at 8 o'clock. She will give us a lecture about the relationship between immune deficiency and the bone diseases. That's why we will shift to Dr. Samira Ghallab. She will be our next speaker. She will speak about the golden week for newborn. Dr. Samira Ghallab is a consultant pediatrics in Saudi German Hospital, Riyadh. She's our colleague in the pediatrics and in ICU. Hello, Dr. Samira, you can share.
السلام عليكم ورحمة الله وبركاته. Dr. Amin spoke in a few minutes before about the golden hour, and here I will speak about the Golden Week project. It is actually continuation of the golden hour guidelines, and we started to apply this project in our unit, inshallah, from the next year. After we succeed in the application of the RDS pathway, which we applied from starting from 2019-2020 for all preterm babies less than 37 weeks and who are diagnosed with respiratory distress syndrome in the first 3 days of life. And this project was applying medical and nursing care in a specific systemic way with family education and involvement with the applying of the golden hour policy. We took the retinopathy of prematurity and bronchopulmonary dysplasia and the length of stay as a measuring outcomes. And this showed great improvement in the morbidity and mortality outcome in our cases. It was much observed in the retinopathy of prematurity cases that needed injection or release of photocoagulation. They are much decreased, and the retinopathy and the bronchopulmonary dysplasia also the severity decreased much than before application of this project. I will not speak about details because I have a few minutes. The Golden Week project is a project aiming to decrease the morbidity and mortality with applying efficient guidelines through the first week of life, concentrating on the extreme preterms before 28 weeks gestation. So we'll choose the extremes, those below 28 weeks, and we extended the period from to be golden from the first hour until the age of 7 days. This project was first applied in 2017 in Alabama, and they took, after application of this Golden Week, they took the mortality in the first week and the periventricular interventricular hemorrhage as outcome measures, and they concluded that there is much decrease in these two in the morbidity of interventricular hemorrhage and the mortality in the first week. And they, in the interventricular hemorrhage, they concentrated on the severe forms, the grade 3 and grade 4. So the Golden Week project is an evidence-based standardized quality improvement plan established to improve care and outcomes of premature infants born at gestational age less than 28 weeks, and so decreasing the mortality and morbidity. The team included in the project includes the NICU staff from the NICU consultant, physician, lead nurse, charge nurses, staff nurses, with DR staff, delivery room staff, and the obstetrician. The quality department, the social workers, the parents, and the breastfeeding consultant or specialist in the NICU unit. The Golden Week is divided into 3 periods. The first period is the golden hour. First golden hour. The second period is the period between 1 and 72 hours. And the third period is the remaining days of life until 7th day of life. And it concentrating, or it was created in 5 broad clinical categories and 2 non-clinical categories. The non-clinical categories included the staff and team building and the parent support and satisfaction. And the medical categories including the respiratory support, thermoregulation, nutrition and fluid management, infection prevention and control, and neurological status. All these are applied in an evidence-based way to improve the morbidity, to decrease the morbidity and mortality of this patient. For example, the respiratory support with its aim to decrease the ventilation injury, to decrease the hyperoxygenation or hyperoxia, oxygenation toxicity, and so on. The golden hour, I will not speak much about it because Dr. Amin already spoke about it, but in brief, it is an effective communication and collaboration between multiple care providers using evidence-based protocols and measures with the goal to deliver initial resuscitation, stabilization of a very premature infant in a relatively short period of time, with minimal or no complications or side effects. This chart is, it is recommended that before the attendance of the delivery of any preterm babies, especially those extremes, those below 28 weeks, to have a time frame so everyone of the team will know when he will start to work and how it will work. So, for example, we are starting antenatally with the counseling, then the recommendation of delayed cord clamping for between 30 minutes to 2 minutes, the early initiation of nutrition, either by dextrose 10% or by partial starter TPN, if available, early application of the CPAP, and insertion of the peripheral line or a central venous line, starting of the caffeine within specific time, sampling of the blood and X-rays and application of the surfactant administration. All this time frame for every member of the team will know its role and when it should be started. In general, the golden hour is aiming to avoid the fluctuation in the blood temperature, the fluctuation of blood glucose, the fluctuation oxygenation, fluctuation of the ventilation, and those all to avoid the disturbances of cerebral autoregulation that in the end will affect the morbidity very much, especially the retinopathy of prematurity and the bronchopulmonary dysplasia severity. And there is much strong evidence that the golden hour decreased the hypothermia and hypoglycemia, and its complications decreased the intraventricular hemorrhage, bronchopulmonary dysplasia, and retinopathy of prematurity. The second period is the period between 1 and 72 hours. And this period is the period where most of the cases of intraventricular hemorrhage will appear. As we know that this patients below 28 weeks, about 50% of them will have some degree of periventricular interventricular hemorrhage. 50% of them will appear in the first day, and most of them about 90% will appear by the third day of life. Also, this period is the period of ventilation injury that can happen, and the period we can establish the use of colostrum early in life and take the benefit of it. This period will include two parts. The first part is that is the continuation of the golden hour, as Dr. Amin spoke in his presentation, plus implementation of a bundle. Its aim is to decrease the periventricular intraventricular hemorrhage, and this is the main bundle that we will concentrate on our project to be applied in our unit, inshallah. This bundle includes six areas. The first one is to centralize the position of the head of the patient, avoidance of physical therapy maneuvers in the first 3 days, avoidance of ATT suction, and if we have to do CSF, we should postpone until the passage of the first 3 days, and the daily assessment of the weight should be delayed or hold it until the passage of the first 3 days of life, or we can use the incubator service, the facility to take the weight automatically by the incubator without moving the baby. It is okay. Reinforcement of the minimal handling and environmental policies. And of course, we will follow by the cranial ultrasound the development of the intraventricular hemorrhage and the documentation of its presence and its degree. This study was done and showed the significant reduction of the periventricular intraventricular hemorrhage occurred, and it is about 10% decrease from the previous cases. The third period is the period between the 4th to 7th days of life, and it should include continuation of the same clinical and non-clinical categories with concentration on minimal handling, weaning from mechanical ventilation and oxygen therapy, discontinuation of the IV antibiotics if no infection, and the early diagnosis of infection if happened, putting the plan for neonatal screening as per policy, family support with their involvement in the plan of management, and expected time of discharge, prognosis, and outcomes. And the family usually included in the management of the patient from even before the delivery. And they have information continuously about the plan, the progress of the condition, the prognosis, the expected time of discharge, the screening procedures that the patient or the baby should have before discharging home. And at the time of discharge, they should know how to follow up after that. Support the breastfeeding, breast milk feeding with involvement of the breastfeeding consultant or specialist, with follow-up of the BIVH severity if occurred with cranial ultrasound. Outcome measures, we can measure, there's many issues can be measured from this project, including the IVH grades, grade 3 and 4, mortality in the first week or on long term, weaning from oxygen, length of hospital stay, compliance with breastfeeding and use of colostrum in the first 3 days of life. And this colostrum has, as we know, that this has many benefits. And we are in our unit, we are trying to get the colostrum as early as possible in the first day, and we are applying it to the buccal mucosa of the preterm daily, and even we can put in the skin of the patient if and starting early enteral feeding with it. Also, we can measure the retinopathy of prematurity as outcome, and bronchopulmonary dysplasia severity also can be measured. Conclusion, Golden Week is a continuation of the Golden Hour application after its confirmed effect on decreasing morbidity of the neonatal outcome among preterm babies. Golden Week is targeted for extreme preterms delivered before 28th week station. applied through the first 7 days of life, applying the bundle to decrease the severity of periventricular intraventricular hemorrhage has promising outcome. Bolton on the good quality practice have a promising impact on the better prognosis, decreasing mortality and morbidity on the short-term and long-term outcomes. Thank you.
Thank you so much, Dr. Samira, for your nice presentation. Now we'll move to our next speaker. Our next speaker will be Dr. Iman Al-Masharawi. Dr. Iman Al-Masharawi is a senior consultant otolaryngology, pediatric otolaryngology in Prince Sultan Military Hospital in Riyadh. Dr. Iman will speak to us about approach to a pediatric foreign body aspiration. Welcome, Dr. Iman. You can share your presentation.
Yes, hi. Good afternoon, everybody. I'm trying to share my screen.
I cannot hear you. Still, you are not in what? And I can see your picture, but I cannot hear you.
Hello?
هي في العربية تقريبا.
I think we can hear Dr. Iman, but we don't see the slides from her side.
لو أنت من الموبايل، إذا الموبايل كونكتد على السيارة، افصليه من على السيارة، افصلي
لا لا
عشان
لا لا
صوتك
لا
يوصل.
أنا مش من السيارة. This is not a mobile. It's
لا مش سامعينك.
الصوت واضح دكتور، الصوت واضح. We can hear her.
You
دكتور
can
إيمان
hear
السلام
me.
عليكم. تمام دكتور إيمان تفضلي.
طيب بس ثواني، بس أعمل شير السكرين. ثواني بليز.
دكتور إيمان معاكي علاء الدين بخاري، إذا تسمحي بس
أستاذ علاء، حد ممكن يساعدها؟
ستوب شيري وارجعي اعملي شير مرة ثانية.
طيب أوكي أنا هفتح المحاضرة.
تمام.
أيوة
بس.
كده ماشي، بدأنا نشوف كويس.
أوكي.
الصوت بقى كده تمام، الصورة تمام والبرزنتيشن تمام، باقي صوتك أنت.
تمام. الصوت الآن واضح.
دكتور الصوت راح.
لو حضرتك في سيارة افصلي الموبايل من على السيارة، ما تخلوش كونكتد مع
لو أنا
السيارة.
في السيارة أفصل الموبايل. طب
اقفلي
إيش دخل
البلوتوث.
الموبايل؟ الآن صوتي واضح؟ ألو؟
واضح دكتور، واضح تفضلي.
واضح؟
واضح دكتور
أوكي.
تفضلي.
Can I start؟
يس يو كان، تفضلي دكتور.
طيب يعني I choose this topic.
لا احنا مش سامعينك خالص، مش سامعينك.
طب كيف في
صوتك
ناس
مش واصلنا
سامعاني يا
خالص.
دكتور نبيل وناس مش سامعاني؟
دكتور الصوت طالع دكتور، الصوت واضح.
سيب القهوة
دكتور
بس دلوقتي أو العصير
اللي مش
وركزي
سامعني
معايا.
بس.
تفضلي دكتور،
إيه؟
تفضلي، الصوت طالع، تفضلي. جايز دكتور نبيل مع
مش
الصوت عنده
سامعينك.
بس واضح. تفضلي دكتور.
Okay. I choose this topic mainly because
سامعك.
of the cross relation
طيب كده
between.
خلاص، الصوت تمام كده، توكل على الله.
Okay, it's the cross relation between the pediatric ENT as well as the pediatric in general. I will present a scenario and we will go together and see the difficulty in diagnosis in these patients. Imagine that we are in the pediatric emergency room. This is the scenario. Receive a call, 2 years old child was playing and suddenly he started to have repetitive cough. Now 6 hours prior to the hospital presentation. The child is still having on and off cough, no cyanosis, no witness shocking. So this is always the dilemma. There is no clear witness shocking of a foreign body around. You feel the child was playing, he's crawling, he's 2 years old, either he's or sometimes younger than 2 years old, playing with his brothers and sister, and you never know what's happened. And we present the dilemma. So let us know about the epidemiology of foreign body. Foreign body is a common cause of mortality and morbidity in children, especially in those younger than 2 years. Before the 20th century, aspiration of foreign body has a 24% of mortality rate, and this caused by suffocation following foreign body is the 5th most common cause of unintentional injury mortality in the United States, and the leading cause of unintentional mortality in children younger than 1 year old. So we are talking about a serious issues here. Approximately 80% of our pediatric foreign body occur in younger than 3 years old, and the peak incidence is between 1 to 2 years old. And this is the natural scenario where we can see children playing with المسبحة, playing with especially المسبحة. The family الأب سامعني دكتور نبيل؟
سامعك كويس.
اوكي لانك بتضحك مش عارفه ليش.
لا بضحك على موضوع تاني عشان قلت لك سيب العصير.
مش عصير، هذه مي. طبعا a common picture where I can see children playing بالمسابح هذه عادي جدا عند الأهالي، وعشان كذا part of our job is the awareness about the seriousness of this condition. التايب of foreign body احنا بالنسبة لنا in the Middle East most probably is the vegetable يعني vegetable seeds. في Middle East is more of the watermelon seed, like مثلا في other countries they have the peanuts. Non-food items they are more common aspirated in the older children, and one of the serious things to aspirate is the toy balloons or similar object, because it causes absolute airway obstruction, and most of the patients die before they present to the hospital. Factor that make the foreign body more dangerous is the roundness. The more it's round, it's very easy and very slippery. It's more to at ease it will go into the trachea and into the airway. طبعا nevertheless we can remember inhalation of pills. البills اللي فيها sometimes it will dissolve and cause intense inflammation. And alhamdulillah this kind of foreign body صراحة يعني I have never during my whole 17 or 20 years of experience I never saw an inhaled pills as a foreign body. طبعا نيجي نتكلم what are the most common location. يعني خلينا نقول الحمد لله انه larynx usually is not the most common, because usually foreign body in the larynx is يعني associated with high death rate. So larynx is 3% and the trachea and carina is 13. And as we know, you can see from the dimension, from the shape of the how we can see the sliding of the right bronchus is foreign body is easily lodged into the right lung, and طبعا the right main bronchus is the most common. Then after that we can see اللي هي 6% in the lower bronchus and less than 1% in the middle loop bronchus. Left side of the lung is 23%. طبعا bilateral it's very rare, and we saw it only with patient plastic bronchitis. هدول البيشنتس اللي هم post Fontan procedure where they have a lot of lymphatic exudate, and the lymphatic exudate بنسميها endogenous foreign body, and this is an acute emergency. At the beginning of the يعني there is also certain prophylaxis these children they should have, preventing them from going into plastic bronchitis. It's away from our talk, but it's a very, very interesting presentation actually. So always we remember when we evaluate the foreign body and when we think about the foreign body and examine the child, that this foreign body play يعني it's deceiving, because sometimes if it is very big it will cause a stop valve, or it cause a bypass valve, or it cause one-way valve, and all of this, each one of them will cause different presentation as well as different assessment for children when we examine the chest as well as when we do an X-ray. طبعا نيجي نعمل how we diagnose these patients. A history of shocking. A witness shocking is the sudden onset of cough, dyspnea, and cyanosis in a previously healthy child is associated with 76 to 92% that there is a foreign body. So history of shocking is red flag always. What happened? The course of aspiration, if we can see here the diagram, the course of the aspiration, acute episode of aspiration, two courses. Either the foreign body get extracted, or the child he suffocate and laryngospasm and arrest, or he will present with persistence of symptoms and unexplained dyspnea, recurrent wheezing, chronic cough. And in between, he will have a symptom-free period. And if all of this not treated, he will go into a complication, recurrent pneumonia, acute pneumonia, lung abscess, hemoptysis. So sometimes if we don't be very vigilant and diagnose the patient as early as possible, our patient, they will go in this bishop cycle. And it has been a lot of cases we've seen that presented to several hospitals with recurrent wheezing, exacerbation of asthma, and at the end of the day, it was a foreign body inhalation. So as well as طبعا البرزنتيشن هذه بتعتمد على the degree of blockage as well as the location of the object, the age of the child, and the type of the foreign body, and the time elapsed between the inhalation as well as the presentation. طبعا the presentation and diagnosis within 24 hours of aspiration usually occur with 50 to 75% of the cases. طبعا في some of the foreign body, it's a huge foreign body that will demand على طول الريكوجنيشن بيكون سريع فيها الايرواي اوبستراكشن سريع، والدايجنوسيس بيكون اسهل. يعني انا عندي الحالات هذه اسهل بكثير من الحالات اللي بتكون small tiny foreign body. It's not causing complete obstruction. It's misleading the pediatrician a lot in the emergency room. طبعا as I told you, more commonly it causes partial obstruction, and the most common symptoms as well as we mentioned is either the acute witness of choking, or presented later with cough, tachypnea, stridor, or non-specific cough, generalized wheezing. In review 135 cases of an airway foreign body, the classic triad present only in 57 patients. So it's not always the three triad as we think about. The presence of the triad has high specificity but not sensitive. So it's not always the triad of choking, coughing, and wheezing. Why we have a delayed diagnosis? One reason of the delayed diagnosis that the child with a lower foreign body may present with a subtle non-specific symptoms like dyspnea, chronic cough, recurrent pneumonia. Other factor included unwitnessed aspiration, decision by the parent or physician that this child we should not pursue medical يعني extra investigation, or misinterpretation of the symptoms. This is always the cause of the delay of diagnosis in these children. طبعا مشكلتنا في الإكس-راي, unfortunately, all of our foreign body, they are not radio opaque. So X-ray, if we do X-ray in children with a lower airway foreign body, the most common radiographic finding in the lower airway is as we see, hyperinflated lung, and the cause, this is caused by partial obstruction with air trapping, such that an air phase with inspiration, not with exhalation. That's why we need to do inspiratory, expiratory, so we can see the hyperinflated lung. Sometimes in later stage, they present with atelectasis, and usually this is secondary to that this foreign body become, either the foreign body stay for a while, or it's large or swollen that cause complete obstruction of this part of the lung and cause atelectasis. Also sometimes, as you see, midline shift of the mediastinum, and the mediastinum will be shift away from the foreign body side, or they can present with pneumonia, these patients, as an X-ray finding. نيجي نتكلم على CT, because I feel that the CT is one of the most important tool that we might between us and the pediatrician use, and it helps us recently with the case from Saudi German hospital. CT is becoming a very important tool in diagnosis foreign body. It's possible, and in cases with inconclusive radio X-ray, and still the suspicion of foreign body is there. However, this imaging is is helpful if the child is stable, and if there is no witnessed foreign body, and the child is stable, and you are not sure whether there is a foreign body or not, and the X-ray is not conclusive. I think doing CT is very important. Why? CT, it has a 100% sensitivity and specificity from 66 to 100, unlike plain CT. And we suggest to do ultra-fast CT scan is a very useful tool compared to the standard technique. The main disadvantage of the CT scan is the radiation exposure and delay in the therapeutic for bronchoscopy. But what we are doing these days, actually, if we have a child with unwitnessed foreign body, with history of recurrent pneumonia, with history of recurrent wheeze, recurrent exacerbation of asthma, and this child, he was not like a severe uncontrolled asthma, usually what we do, and the patient is stable, we do CT scan, and really it helps. Like this patient, he presented to the emergency room like 1 month back in the Saudi German hospital and the emergency, and the child, it was really the suspicion of an excellent pediatrician. She said the child, there was no witness, and a child was around 1 year, 8 months, was playing with his brothers, and suddenly, according to the mother, she came and she noticed that he was coughing a lot, and after that he was okay, but she was worried because there was a lot of, she just brought him to the hospital. The pediatrician examined the patient. He was completely normal examination. And she said, but still the history, I cannot leave this patient. X-ray was inconclusive. So our decision is to, before taking him, since there is patient stable, and I went to him to see him in the emergency. He was playing, to eat, taking his milk, and completely normal child. We said, okay, let us, since that's a very highly suspicion, better than, because bronchoscopy, rigid bronchoscopy is not without complication, and we've seen a lot of complication of rigid bronchoscopy. So what we did CT scan, and definitely it showed a very clear foreign body. The child went to we did a rigid bronchoscopy, and this was a seed, and it was extracted and removed successfully. So this is that's why but I don't like people to understand that all patients have to do CT scan. Only there is no clear rule who to do CT scan, who not, but our because there is no enough data till now, but our policy that if there is no witness foreign body inhalation, patient is very stable. If you have unstable patient suspecting foreign body, emergency rigid bronchoscopy is straight away. نيجي عاد للأشياء اللي هي why we want to help do a scoring to help us to see who will take him to rigid bronchoscopy, who will do CT scan. And according to this group, they published their article in 2022, and they present the most variable presentation: witnessed shocking, new onset of recurrent wheeze, sudden cough, unilateral diminished breath sound, wheezy chest, respiratory distress, and unilateral hyperinflation, and they gave it away a risk score. And accordingly, they said that the foreign body, the risk score, if it is less than 2, or 2 to 3, or 4 to 5, or more than 5. They noticed that if it is 4 to 5 or more than 5, the positive for presentation of foreign body with this scoring system is around 87, reaching to 100% in if the score is more than 5. It's a very excellent score, but is unfortunately still it's need standardization and need multi-center approach. But I feel what we are planning to do, starting multi-center study using this score to help us, because really from I can tell you from 20 rigid bronchoscopy I do over the last 3 months, the foreign body was there in 7 or 8 cases. We end up taking a lot of patients for foreign body, and still there was no foreign body in these patients. As we mentioned here, if it is less than 1, we for close follow-up, 2 to 3 flexible bronchoscopy can be done, 4 to 5 flexible or rigid, more than 5 is rigid bronchoscopy. طبعا في الحالات life threatening situation we know that this is يعني I think this is ABC for all the pediatrician how to perform يعني the helmet maneuver and in case of acute foreign body ingestion or inhalation, sorry. So if you have a moderate high risk patient with a history of choking and suspected cyanotic spill, the tracheobronchial tree, we should examine him and do rigid bronchoscopy. With low suspicion cases, as we mentioned, we can wait on them. And this is an algorithm. I feel that this is the take-home message from this algorithm. I feel that this is the most important algorithm. If you have a suspected foreign body, if your patient is symptomatic or asymptomatic, على طول we have to have an emergency management for airway obstruction. We'll take him to the OR. Asymptomatic patient, these are the dilemma patient. We'll take them to do plain X-ray show foreign body detective على طول bronchoscopy. If the X-ray plane showed normal or equivocal and the history is very low suspicion, we can observe. If there is high risk suspicion in the history, we'll do CT scan in these patients. CT scan will help you if it is suggestive of foreign body bronchoscopy. If it is negative, we will follow them up, observe and follow up in the clinic. I feel يعني if we carry on with this algorithm, inshallah we will be very safe in dealing with all of our children with a suspected foreign body. طبعا as we mentioned, rigid bronchoscopy is a very useful tool, but not without complication. There will sometimes we have a severe laryngeal spasm. Sometimes we end up by having pneumothorax, unfortunately, or trauma to the lung. So the rigid bronchoscopy, usually post rigid bronchoscopy, we need to have the patient admitted to the ICU for at least 6 hours. So rigid bronchoscopy is an useful tool, but not without risk. Nowadays, we have an excellent tool, what we call it flexible, with the flexible bronchoscope, and we can have a very nice tool, a graphing forceps can be introduced within the flexible bronchoscopy, and I think the Saudi German hospital group, they have this flexible, but these, unfortunately, they are still, the diameter is big, is more or less more for children above 6 years old, but it's a very, very useful tool for, especially for the distal foreign body, and for this fragmented foreign body to be removed, we can use the flexible bronchoscopy. And the flexible bronchoscopy طبعا is less risk than the rigid bronchoscopy. But يعني, as we mentioned, always still the rule of flexible bronchoscopy, most of the ENT, they said, no, we need to, يعني, most of the literature till now is not supportive of the flexible, but for us in our practice, we use the flexible for children above 6 years old, and also we use it for, if we are suspecting distal foreign body, at least we use the smaller one for lavage, so it will help us to clear the infection. And sometimes we do this with our, combined with our colleagues in pediatric pulmonary, who usually they do a great help with us in this part. يعني, this is a repetition of whatever I have said before. So my take-home scenario that I will repeat again, a simple scenario, but you need to go and dig in the history, and after that do X-ray for your patient. If you are suspected and the patient is stable, do CT scan, consult pediatric ENT, and sometimes at the end of the day, the rigid bronchoscopy is the golden standard to rule out foreign body inhalation in these children. Thank you very much.
Thank you so much, Dr. Iman, for your nice presentation, and thank you for the great efforts you are helping us in the management of the airway in our ICU. Thank you so much for being with us, and sorry to disturb your
لا والله هذه مية بس عشان
لا مش
في أي أسئلة بس عشان
لا لحد دلوقتي ما فيش. لا شكرا.
طب كويس، شكرا.
Thank you. شكرا. Thank you so much.
هلا أهلا، شكرا.
مع السلامة. We'll move to our next speaker. Our next speaker will be Dr. Rami Mustafa. Dr. Rami Mustafa is our colleague here in Saudi German Hospital, Riyadh. He is a consultant of general pediatrics, and he is the director of the diploma training program of the Saudi normal training program that started this year in our hospital. Dr. Rami will speak about lymphatic disorders in newborn. Welcome, Dr. Rami, and you can start.
السلام عليكم ورحمة الله وبركاته. Screen now is
تمام. Your presentation is okay, voice is okay. توكل على الله.
First of all, I would like to thank Dr. Nabil for his kind invitation. Today we will talk about the lymphatic disorder in pediatric and newborn. I will start with my presentation with two case scenario. The first is 38-weeker diagnosed antenatally as massive pleural effusion, bilateral, so postnatal bilateral chest tube was inserted. Pleural fluid analysis revealed lymphatic lymphocytes with 95%, so diagnosed as chylothorax. So we started TBN and kept the baby MBO, kept mechanical ventilation. Chest tube still getting a significant amount of pleural fluid. So the baby started on octreotide infusion and MCT-based formula was started. In this baby, the chylothorax take about 63 days to be resolved and then removal of the drain after repeated insertion. And as we see here in the X-rays, the sequence of the case started with massive pleural effusions, then the drain insertion, then finally we get free baby from the chylothorax. The second case is preterm 33-weeker Down syndrome, non-immune hydropsy fetalis, bilateral pleural effusion with generalized edema and ascites. The baby also has esophageal atresia type A. So after the delivery, bilateral ICT was inserted. TBN also was started. Pleural effusion was improved after insertion, and so the drain was removed. This baby has a gastrostomy as he has long gap esophageal atresia. So after starting the feeding with the gastrostomy, the recollection of pleural effusion was done. And by lab examination, we noticed that the pleural fluid revealed the chylus in nature. So the baby kept MBO, TBN started, and feeding was restarted with MCT-based formula. The chylothorax in this baby take about 3 weeks to be resolved and then removal of the drain. So now the question, what you think, if this management is good management or we have a better pathway to get? This one, anyone has any opinion? No one. But for me, I must first to go deep for the lymphatic disorder pathophysiology. If we see here the pathophysiology, the anatomy of the lymphatic pathway started from the periphery and then collected to reach to the thoracic duct, then going to the venous system. To understand good the pathophysiology of the lymphatic disorder, the pediatric lymphatic flow disorder present a unique disease spectrum with specific challenges and consideration. The immune's recent advice of advance in lymphatic image and therapeutic have allowed the identification and the treatment of this diversity symptoms from neonate to adolescent. The innovation of dynamic contrast enhanced magnetic resonant lymphangiography has a big role to understand the pathophysiology of this category of disorder and visualize the anatomy and function of the lymphatic system, has identified several different image patterns, allowing the better understanding the pathophysiology and helping in the treatment by intervention radiology. According to the magnetic resonant lymphangiography, we can dividing the neonatal lymphatic disorder into isolated chylothorax, chylous ascites, and central lymphatic flow disorder. We will start with isolated neonatal chylothorax, which can be presented on the fetal image or immediate postnatal period, necessitating external drain with chest or pericardial drains. The traditional management, as we mentioned in the first case, through the conservative management, which including diet modification, such as parenteral nutrition or specific medium chain triglyceride formula, and also octreotide infusion. The prolonged lymphatic leak can lead to malnutrition and immune suppression and increase risk of superinfection from drainage catheter. The new diagnosis tool, like the magnetic resonant lymphangiography, can precisely identify the pathophysiological mechanism, allowing effective therapeutic solution, such as lymphatic embolization. As we see here in this image, this is the dynamic magnetic resonant lymphangiography of isolated pleural effusion, which showing typically demonstrated abnormal pulmonary lymphatic flow from the thoracic duct toward lung parenchyma through the branches of the thoracic duct. These branches abut the pleural surface with lymph web into the pleural and pericardium species, most probably this pleural stoma, through pleural stoma. In most of the patients, the magnetic resonant lymphangiography shows congenital occlusion of the distal part of the thoracic duct, resulting in developing collateral vessels that traverse mediastinum and lung parenchyma, which allow the lymph to be collected, especially in the pleural space, producing chylous pleural effusion. Following the magnetic resonant lymphangiography, this patient undergo conventional intranodal lymphangiography using Lipidol. The therapeutic effect of Lipidol as a treatment of chylous leak has been well described and is probably the result of occlusion of a small lymphatic vessel or pleural stoma by oil-based contrast. The using intranodal lymphangiography is performed by position 25 gauge spinal needle into bilateral inguinal lymph node under ultrasound guided, and then Lipidol is injected in the lymph node until there is appropriate stasis within abnormal pulmonary lymphatics. It is very important to limit the amount of Lipidol to 1 to 2 ml divided between each groin node, as large doses may adversely affect the lymphatic system. If the intranodal injection cannot deliver the adequate amount of the Lipidol in the pulmonary lymphatic circulation, so at that time we can catheterize the thoracic duct and do thoracic duct embolization. The second disorder of the neonatal lymphatic disorder is the isolated neonatal ascites. which is considerable more complex to treat it than pleural effusion. Also, we can use it with the conservative management, with keep the baby MBO and start TBN, insert peritoneal drain, and use MCT formula feed. But here, the cause is different than the chylus effusion, as the most common cause of chylus ascites is the large retroperitoneal lymphatic mass visible in T2 weighted image. If the focal lesion is identified by the magnetic resonant lymphangiogram, intranotal lymphangiogram is performed to guide the intervention. The intervention here will be by insertion of 20 gauge spinal spinal needle and in the lymphatic mass, and embolize percutaneously with the glue diluted with lipidol by percentage 1 to 2. If the leak cannot be visualized by magnetic resonant lymphangiography or intranodal lymphangiography, open surgical approach can be attempted and combined with glue embolization, and surgical closure can be performed, and it will be very helpful for this case. This several study started from 2014 and till 2019, showing marked improvement in the cases with chylus pneumothorax, chylus pleural effusion, or chylothorax and chylus ascites after using the lipidol and thoracic duct embolization. Even in some cases, it not take more than 4 days to be improved totally. The third disorder in the neonatal lymphatic disorder is central lymphatic flow disorder. The central lymphatic flow disorder, also described as central lymphatic conduction anomaly, presented as triad of fetal or neonatal pleural effusion, ascites, and diffuse anasarca. This condition presents altered flow through the central lymphatic system without adequate collateralization, and is often associated with Noonan syndrome, Turner, and Down syndrome. The magnetic resonant lymphangiography usually demonstrates lack of progression of contrast through central lymphatic system, indicated central lymphatic obstruction rather than the lymphatic leak. As we see, there is a difference in the pathophysiology in these cases than the chylus effusion or the ascites. The problem here is elevated central venous pressure and is reflecting from the elevation of pleural from pulmonary pressure and chronic lung disease. In these cases, no intervention is indicated, and the treatment focus on reduction of pulmonary hypertension and the conservative treatment of the chylus effusion. Neonate with pleural effusion associated with hydrops has a report mortality from 69 to 75%, which is very high mortality. The magnetic resonant lymphangiography usually demonstrates lack of progression of the contrast through central lymphatic system with dermal lymphatic backflow in the abdominal wall. In case of using of lymphatic embolization in this patient, usually is not helpful, as the main pathophysiology mechanism is the central lymphatic obstruction rather than lymphatic leak. In these cases, we can go to the surgical lymphovenous anastomosis, which can be helpful. Let's go now for the pediatric lymphatic flow disorder, which is most commonly we have the complex lymphatic malformation, blastic bronchitis, and protein losing enteropathy. The complex lymphatic malformation is a group of diseases that involve multiple organ systems, including the lung, bones, liver, spleen, and intestines. These diseases include generalized lymphatic anomaly, cabuciform lymphangiomatosis, and Graham's 2 disease. In the KLA or cabuciform lymphangiomatosis with severe coagulopathy, chronic DIC, and pathognomonic lymphatic endothelial spinal cells on tissue biopsy. The pulmonary involvement is the main issue in these cases because including the interstitial lung disease and or pleural effusion has the significant cause of mortality and morbidity in these cases. The percutaneous embolization of the abnormal lymphatic vessel carries this flow into the lung parenchyma has been reported to be successful in the resolution of pleural effusion and improvement of pulmonary function. The second disorder is the blastic bronchitis, which is characterized by the patient expectorating fibrous white yellowish casts resemble the bronchial tree. In these children seen with congenital heart disease, especially Fontan physiology. The traditional management include airway clearance techniques such as arousal tissue plasminogen activator, nebulizer, chest physiotherapy, but the mortality rate is still high in these cases, ranging from 14 to 50%. The innovation management approach involving dynamic contrast enhanced magnetic resonant lymphangiography to identify the source of abnormal pulmonary lymph flow and lead to targeted therapy by using the embolization show marvelous improvement in these cases. As we mentioned, this is a study showing 15 out of 16 patients treated with thoracic duct cannulation and embolization of abnormal flow had significant symptom improvement and effective treatment and the medical therapy for effective termination of the medical therapy for the blastic bronchitis. The last disorder we can see in the pediatric is protein losing enteropathy. The protein losing enteropathy is characterized by excessive loss of protein in the gastrointestinal tract, resulting in hypoalbuminemia, hypogammaglobulinemia, lymphopenia, and deficiency of fat-soluble vitamins. This deficiency led to anasarca, ascites, pleural effusion, immune compromisation, and failure to thrive. Also, this case is associated mostly with single ventricle patient. The diagnosis of these cases based on increase of fecal alpha-1 antitrypsin and the conservative treatment include low-fat diet, loss replacement with albumin, intravenous immunoglobulin infusion, and steroid. The intervention innovation approach can be used in these cases, especially in the lymphatic congestion, protein losing enteropathy, which is associated with the congenital heart disease, which showing good response for this intervention. As we see in the presentation, currently the role of intervention radiology and magnetic resonant lymphangiography is increasing in the treatment of lymphatic disorder. But still there is some obstacles, like the smaller size of the children, especially infant, which makes the access of lymphatic system with currently available equipment more challenging. And the need, as a neonatal thoracic duct is often accessible only to the 25 gauge needle, which make the effect of embolization very limited. And also the children has a more susceptible to radiation damage, necessitating minimize fluoroscopic time and dose during procedure. Also, the operators must consider limitation on iodinated contrast, dose, and heat loss due to relative large body surface area in children, emphasizing the need for precautions and skill in treating pediatric lymphatic flow disorder. Conclusion. The pediatric lymphatic flow disorder present a unique disease spectrum with specific challenges and consideration. Recent advances in lymphatic image and therapeutic have allowed for better identification and treatment for this condition. The dynamic contrast enhanced magnetic resonant lymphangiography has become pivotal in providing accurate diagnosis and classification of neonatal and pediatric flow disorder. Innovations in lymphatic intervention, such as thoracic duct embolization and lymphovenous anastomosis, offer curative options for various lymphatic disorder, reflecting the rapid growth in the field. As the field progresses, clarity in the classification and organized treatment approach are essential for improving outcome in this vulnerable pediatric population. Thank you.
Thank you so much, Dr. Rami, for your great presentation. I will just add a comment on your second case, the child with lower trisomy 21 and esophageal atresia and long gap. Actually, this baby, we gave him a chance for about 3 months to be a little bit bigger. Then he was operated on Saturday. In a very long operation in our hospital here, and he opened thoracotomy. He did not find any lower esophagus part, and then he opened laparotomy, and then he found a small esophagus. He pulled up the stomach and used it as a tube in the chest, and makes the stomach itself as the part of the esophagus, and done the esophageal repair. It was about 8 hours operation, and as reported by the surgeon, Dr. Tariq Al-Tuqais, who told that is one of the most difficult cases because there was no actually esophagus. And others sometimes are going with transplant from the small intestine, but he preferred to be from the stomach as it will be more physiological, and maybe he is hoping that it will be okay for this. The baby is in the day 3 operation now, is still a little bit critical, but improving. We hope that he will pass, inshallah. Thank you so much.
Thank you.
شكرا دكتور رامي, شكرا جزيلا. Now we will move to the new era. Our next speaker will be Professor Dr. Muhammad Hani Timsah. Dr. Muhammad Hani is a professor of pediatrics.
دكتور صوتك راح. دكتور صوتك مش سامع اسمه.
الصوت مش مسموع؟ كده الصوت
معلش صوتك مش
مسموع؟
مسموع.
كده مسموع؟
لا مش مسموع لسه، معلش.
لا اله الا الله. طيب كده تمام.
جرب الحين.
سامعيني كده كويس؟
برضه.
ده انا حتى بزعق يعني. اه صوتي مسموع كده؟
اتفضل الحين.
كده كويس؟
السلام عليكم
تمام.
دكتور
طيب
نبيل.
حضرتك
دكتور
خلاص
هاني
قدم الدكتور.
سامعني؟
الصوت شوية شكله بعد 3 أيام متواصلة ماراثونيك ساوند.
والله صوتي حلو.
الله دائما حلو، ربي يكرمك.
طيب
ربي
كده
يكرمك.
الصوت واضح؟
الصوت واضح إن شاء الله، ما أدري مع الزملاء.
طيب كده واضح يا استاذ علاء؟
كده واضح كده واضح كده واضح تمام.
طيب تمام. So our
اتفضل.
next speaker will be Dr. Muhammad Hani Timsah. He will take us to the new era of artificial intelligence. Dr. Muhammad Hani Timsah is a professor of pediatrics in King Saud University, and he is a consultant of pediatric ICU in the medical city of King Saud University. Dr. Timsah has more than 250 publications, about 25 studies of the artificial intelligence. His talk will be about the artificial intelligence and pediatric. يعني for us it will be a new era, and we hope that يعني we will not be surprised too much. اوكي دكتور هاني ويلكم. شرفتنا طبعا بالمشاركه واهلا بيك، وتقدر حضرتك تستارت your
ربي
presentation.
يكرمك. Many thanks Dr. Nabil and the colleagues. You can hear me well and you can see my slides, please?
Yes, everything.
Okay, perfect. So again, thanks for the kind invitation. It's my honor to rejoin again, but this time with a different hat. This time is the hat of the AI, which became very much trendy since the launch of ChatGPT mainly. I'm gonna just to speak briefly about the background. So apparently it's been quite a very quick, rapid journey, but my focus today, I'm gonna try to focus with our colleagues, pediatrics from various subspecialties, how we can utilize it more and more with some background elements that I will be sharing with you. And then we can maybe have a live demo if we have time still permits. So as I mentioned, my aims would be mainly to just to educate myself and my colleagues about the roles, various roles that are potentials in medicine, and some of them specifically in pediatrics, although there are so many of them now that I cannot just, it needs actually a full workshop to go through the details. But my aim is just to have a quick snapshot of it, and how we can have some practical adoption into our practice, and what are the potential, how to inspire some of us to go into future innovations in using it or in research. Of course, I'm more interested in research, like that's life. To start with, I don't have any conflicts of interest to disclose, and I will not be promoting any specific AI model, whether it's ChatGPT, whether it's Gemini, whether it's other models. I'm not promoting for any of them. I'm not endorsing them. Myself, I use ChatGPT and its companion DALL-E 3. This is my own personal usage. But again, all of them, they have so much similar patterns, and some of them, they have more advantages over the others. So what is AI? Just to start with a general question. So of course, it refers to the simulation of a human intelligence into a machine algorithms to think and learn like a human. So this is basically what AI means. And of course, it's relevant to our pediatric field since it could help us to analyze complex big data to probably enhance diagnostic accuracy, treatment plans in pediatric care for the children, for their families, and for our hospitals. So just quick distinction between what are the AI, this is a broad spectrum field of the computer science. An example of it is the virtual assistants like Alexa, Siri. These are examples of AI. If you go to some terminology, machine learning, this is part of the or a subset of AI, which enables the systems to learn from the data and improve their performance as things go over time without being explicitly programmed by the humans initially. Example of machine learning is the email spam filters that adapt based on the user behavior. So this is just a quick example for us. Going to another terminology, deep learning. Deep learning, it's a subset of machine learning that utilizes artificial neural networks with multiple layers. That's why they call it deep. So there are multiple layers to model complex patterns in data. Example is the image recognition systems that identify objects within a photo. So this is just an example of a deep learning process. Going to the neural networks, I know there are so many jargons here, and I don't want to trouble you with them, but it's important to try to differentiate, know what is AI, the one we are focusing on today in the next few slides. Neural networks, these are computational models inspired by the human brain structure, consisting of interconnected nodes. That's why they call them neurons, that process data inputs to produce outputs. Example is the handwriting recognition system. This is something from like the neural network. Going to the last inner circle is the generative AI, which is a branch of AI that focuses on creating new content such as text, images, music, by learning patterns from existing data. And a common example is the ChatGPT that was launched. ChatGPT 3 was launched on a wide scale in the late 2022. So there was previous ChatGPTs, but the model that became very popular spread is 3.5, was launched in December 2022. And there are, of course, other AI models that generate somewhat realistic human faces, compose music. And just to show you in a nutshell what we have been talking about. So the AI, look at it as a big circle. And by the way, this is not my drawing. This is the literature. This is the reference for this drawing. So the artificial intelligence, it's again the technique that equips the computers to use the algorithms, al-Khwarizmiyat, to simulate human behavior, enabling them to make more decision-making rather than just being a simple computer software. The machine learning is it's embedded in the AI, so it's a subset of it, and uses advanced algorithms to detect patterns in large data sets. And then going to the deep learning, which is a subset of machine learning, which uses the neural networks, as we mentioned. And the last one is the generative AI, which will be one of my focuses during this topic about generative AI, which is a subset of deep learning that generates content like text, images, codes based on the provided input. And it is trained on vast data sets. These models can detect patterns and create outputs without explicit instructions, using a mix of supervised and unsupervised learning. So supervised means there is a human interaction with the model. Unsupervised means that it's all by itself, autonomous. And I'm gonna put some QR codes here. So if you're gonna take a screenshot of this one, for those of you who would like to read more about this various types of AIs, there's a nice videos. This is from the IBM website. So you can take this one as a first screenshot, and the slides will be also shared with Dr. Nabil. For anyone who would like to have the slides, more than welcome. Let me go through some examples. So now we know what's the AI models we are talking about. I'm going to show you just some quick examples of how the pixels evolved over time. The pixels, which are the smallest data sets, how they are evolving, and they are evolving faster and faster over time, especially in the last years. So this is one by Dr. Sean Kinsey, who said, while I was skeptical at first about the digital pathology, He is now faster in reading and signing out cases digitally than I was when doing manual review. And this is, of course, because you have repetitive data from the pathology point of view or the X-ray point of view that the machine could easily recognize the patterns and automate it for you in more faster, more precise way. And then the humans, they just need to double check the output, make sure it's accurate. And that makes more efficient use of the AI in our practice. Going to another model about the imaging. So what was previously thought as impossible, there are so many things now becoming possible. For example, the AI-enabled imaging and diagnostics previously thought impossible. It's becoming more with, of course, there are so many giant companies. One of them is the Google Health, which are investing heavily in AI models, so to help the communities, the healthcare providers, to optimize their efforts. Going through another pattern is through the skin and the AI, and this is just an example. As I told you, I'm gonna just show a quick examples before we go to a live demo. So this is an example of how AI has been widely adapted into a skin scanning apps, such as this that is used for development and assessment of AI-based tool for skin condition diagnosis by primary care physicians and nurses practitioners in teledermatology practice. So it's taking the advantage of empowering the telemedicine in reaching out to vast majority to remote areas that could improve the diagnostics, improve the identification of disease. And this is, of course, applicable for us in pediatrics. What kind of skin rash is this? Is it viral? Is it something serious? Something? So these are just examples of how the use of multiple readers, multiple case diagnostic studies that were developed by an AI-based tool, evaluated its utility among 120 different skin conditions. And the AI assistance was significantly associated with higher agreement with a reference diagnosis. And this is just basically improving with time. So these, I'm sure we're gonna see it more and more. And I do hope that our physicians, our healthcare providers will become more adapting for these technologies, such as what I'm gonna show you later on in a few slides. Another widely used tool that have taken pioneer among our physicians and AI, the companionship between them, is the disease of the eye. So using AI to prevent blindness. This is an example of how they made it an automated retinal disease assessment to help the healthcare providers to detect diabetic retinopathy with future possibilities of AI algorithms to assist clinicians in identifying other diseases. And this is a bit old, this paper I'm quoting here, but I just wanted to show you it has been there for a while, but maybe now we are focusing on it as it's evolving faster and faster. And this is just beyond diabetes. Look at this paper about AI and retinopathy of prematurity, which they developed a machine learning algorithms and found it not less accurate than the human experts. And they mentioned that the authors mentioned that it holds considerable potential for as automated diagnostic tool for ROP. So these are expanding. Remember, whenever a research is published, it usually like 1 to 2 years before it's been ongoing. So we're gonna see more and more going out in the near future. AI and cancer screening. Again, this is just showing how the AI systems could really pave the way for us for clinical trials to improve the accuracy and the efficiency of several cancer types, such as breast cancer, lung cancer. And it's gonna come more and more into the pediatric. Usually it starts with the adult, as you know, the literature starts initially adults and goes to pediatrics. And I just want you to have the imagination in our minds that the future is gonna be huge since we are having more and more of the quantum quantum computing. So as more advanced AI models are introduced, as more quantum computers are able to process vast amount of data, then we will be seeing more progress. Of course, there are competitions and like in the market, it's a big share for which company will be able to invest more and launch more models before the other companies. So we're gonna, hopefully that we're gonna have more benefit for our patients with this healthy competition between them. Think about also AI and patient safety. So AI-driven error reduction, it's a possibility and it's coming. The predictive analytics for early intervention, especially for me, I'm in the PICU side. So of course, in the pediatrics, early recognition of sepsis or other life-threatening potentials. So imagine an earlier intervention or earlier recognition of what could be a life-threatening. So why not the machine by itself with the sensors, with the computer electronic health records, it could automatically detect and activate the pediatric rapid response team before it's happening. So these are all potentials. We will be having enhanced diagnostic accuracy. We will be having more customized patient care plans, which will definitively give more patient satisfaction. And hopefully we'll be having improved perioperative or care or chronic care. So all of these are potentials. As a technology being adopted, I'm just going to show you, this is from the technology adoption life cycle. And this is, again, the reference for it if anyone would like to have a look on the full access. So if you see, when it started, I will be focusing about ChatGPT, although I've been talking about AI before the ChatGPT was launched. But look at how any technological advancement starts. There is something called initially the innovators, those who will start early in the technology, any technology that would be. And then you will have the early adopters, okay? And then you will be starting to have what's called early majority. Later on, I believe we are in this phase now, the late majority, and then there are the laggards, or those who just later on they follow. So I believe we are somewhere here, and I do hope that I will convince any of you who didn't use one of these large language model or generative AI, just to start using them now, because it's the earlier the better. And one of the common issues we keep hearing among the AI webinars or discussion is that AI, is it gonna replace physicians? Is it gonna replace nurses? Is it gonna replace healthcare providers? And always the message is no. It's gonna just, those who use the AI appropriately, of course, those who use it, so physicians who use the AI appropriately, probably they will be start to replacing those who do not use it. So again, so this is the ones, the laggards, the one who lag behind. These are the ones who may have less work share in the future. So you have to be cautious. And this is another paper, if you want to scan this code or screenshot it. I'm just here comparing when ChatGPT reached its first 1,000 publication on PubMed, it was in September 2023. Now it has reached already almost 5,000 papers on ChatGPT. So if you put a search word in PubMed, you will find now almost 5,000 papers. So that means there are 5,000 research medical-wise on ChatGPT. I'm focusing again on healthcare. And as ChatGPT and other large language models, LLMs, this is large language model, as they advance further, we will surely see more healthcare roles expanding, highlighting the potential clinical and research roles. So this is so far the good side. Now let's talk about the bad side, because always you have a balance. In medicine, we like to balance, we call it the risk-benefit ratio. So I have spoken a lot about the benefits, hopefully benefits, but what about the risks? Are there risks of ethical issues with AI, with the generative AI, ChatGPT? Are there ethical concerns? Yes, there are. There are. And just an example of them, They call it the ChatGPT or AI hallucination. So they describe the word that it could hallucinate. And this is just an example of a research we had with other colleagues that I was honored to work with at my university and also in other universities, other hospitals. It was a multidisciplinary team. It's never a one-man show anymore. So this is an example when we asked the AI, the ChatGPT, to draw several congenital heart disease. And any one of you who's interested to look at how the AI performed in this particular quest, he can just scan this code for a full paper. It's open and open access in this. So if you can take a screenshot. However, we found that there was a huge hallucinations, and I'm just gonna show you this hallucination. If you look at this one, when you ask it to draw the coarctation of the aorta, so we asked the ChatGPT model, which is called DALI 3. We asked it to draw the coarctation of the aorta. This is what it drew. And please be careful when I use about ChatGPT or other models. Make sure that you are referring to it as it, not as he or she. They are not humans, because some people start to talk about AI or ChatGPT as he is doing that. No, it's a machine. It's an algorithm. So it drew the coarctation of the aorta like this one. So you look how much hallucinated, how much fake, how much artifact is there. And this is a picture of a heart, normal heart, which the evaluators in this particular paper, they found that this is the least hallucinated among the pictures. So still there is a big gap. They look attractive, but they are from another, they don't relate to the reality yet. So just to make sure that when we are using an AI in medicine, we use it as a supplement to our medical practice. We can use it to make collaborative decision-making, to use it in diagnostic aid, enhancing clinical training, personalized medicine, operational efficiency, continuous learning loops. However, we have to keep in mind that it will still continue to hallucinate, although the hallucination is less now if we compare it to previous, but still it hallucinates in the, either hallucinates in its generated text, or it hallucinates also in the references. And those of you who checked before that, asking AI to give it a paper, it will give you a wrong reference paper to a wrong paper, but it's becoming less with time. So the colleagues at King Saud University with Prof. Khalid Al-Malki and Dr. Fadi Al-Jam'an and the team, we worked on something called the reference hallucination scores, so we can compare between medical AIs, chatbots, to see what are the reference, are they accurate or not. And this is the score which is available, open access online. You can scan this code and you will have the online calculator for the reference hallucination score. Please feel free to use it. This is how it's calculated. And once you enter the numbers or the scale, it will automatically generate for you how much this AI generated reference is true or hallucinated. So just to wrap up my topic, so developing a systematic approach to choose which AI tool is more suitable for me. So you have to identify what's your main aim of using which AI model. Check which are the most available and what's mostly usable tools. And initially you can use the free tool before you commit yourself to a subscription. For example, ChatGPT, there is a free model for it, but it doesn't have the full capacity, but you can still try it, ChatGPT. So is for the Copilot with the Microsoft, so is the Gemini with the Google. So you can try them and see which model fits you better, because what you may need for your practice may be different from what the other colleagues needs. So again, it's a trial and error on a personal basis. However, they have all similar functionality. Just to keep in mind, let me check the accuracy myself. Is it accurate? This model, the AI model I choose, is it accurate for me? Is it fast enough? Does it have any data requirement? Is it, can I use it, for example, in my computer and my iPhone? Does it have any regulatory compliance in case you are using it inside the hospital to maintain your patients and data privacy? So to make sure that the AI is not, you are not sharing your confidential data with the AI model. So maybe this is one of the take-home messages also. Besides checking the data if it's accurate or not, make sure when you are using any model like ChatGPT and you ask it a difficult question, make sure you don't put the names, any personal identifiers, name, ID, the name of your colleague. Avoid putting them in the AI chat because you don't know what's being stored there. They call the AI models as now currently as a black box. Black box means it's going there, the AI is using it and it's giving you the output, but we don't know exactly where did the output go, how did it get analyzed. So to optimize your patient privacy, make sure you are not using patient identifiers, please. This is one of the important take-home messages. And if you will allow me to conclude, then we can have, if you have a few minutes, we can run a quick demo. So in conclusion, again, dear colleagues, there is no one size fits all, of course. So start now, don't wait further. And my suggestion is go with a real, if you will choose generative AI, go with a real one. Don't take a proxy AI. Don't take an AI model which uses another AI model. So if I will use, for example, ChatGPT, I will get the original ChatGPT from their developer, not from another company who are becoming like a second, third seller. So no, go to the direct ones. Okay, adapt a balanced integration of AI in your medical practice. So balance it between the risk and benefit. The AI is evolving rapidly in healthcare, and any model could either improve or it could be less improved compared to the others. So make sure that I'm checking a validated benefit for my AI tool, and the cost. Keep an eye on the cost because it may increase or decrease with time. The AI-based medical practice, it's an open field for research and for innovation. And I believe that it's a golden chance for us in the healthcare provision to start building our own models, which is doable. As long as we build it on a solid data, then we can do our own models, which are useful for our patients, for our unique structure in the healthcare systems. Always, we will keep an eye on the ethical and social concerns because this is what we do in medicine, and we always abide by that rules. And I have to thank you at the end. This is my email. If anyone would like to email me, thank you very much. Dr. Nabil, do I have some time to show just one
Yes.
AI demo?
We will go after you in a break, so you can take 10 minutes from the break or 5 minutes as
Okay,
well.
okay. So let me just change the share with your permission. And where is the share again? So I'd like if anyone would like to give me an example. Now you can see my ChatGPT open. So I'm just gonna give you again. I'm not promoting any model. Okay, so I have zero conflict of interest with them, but I just wanted to share with my colleagues some fruitful experience from what I have tried so far. So for example, this is ChatGPT 4o. It's a paid model. And there are other models that I can use. Let me try with a fresh one. Okay. So you can see my screen, I believe. So ChatGPT,
Yes.
you can see it with me? Let me
Yes,
see.
yes.
Yeah. Okay, perfect. So give me an example of what medical question you have in pediatrics, something that comes into your mind. Anything comes in the chat, you can write it, or maybe
Yes,
Dr. Nabil.
we want to ask about the golden week for newborn.
Okay, just tell me about the golden. Of course, you can talk with it. It's easier, but now because I'm using the mic to golden week in the newborn.
Yes.
So let me put, instead of the newborn, I'll put neonatology, so it will understand
Okay.
I'm talking neonatology, because previously they had something called prompt engineering. That means that I have to tell it act like a neonatologist, act like a pediatrician. No, it's not anymore. But once you use medical terminology, it will start asking, replying more. Anything in particular you want to ask about this Golden Week, Dr. Nabil?
No, application. This project is applied where, or you can just write a project application or something.
Okay.
I want to know where it is applied.
Let's see applications.
Yes,
Of course, you
project
can tell
application.
it. Now, this is called ChatGPT 4.0.
Mm.
And there is another one, the ChatGPT OI preview. This one, if you have a complex question, not like simple question. If I have complex question, that's complex case, you can use it. But again, please remember, don't put patient data, name, file number, avoid. And if you want the model not to learn about what you are writing, because the model is learning also about me and about millions of users. So if you want it not to learn about you, you can put this temporary chat. You see this temporary chat?
Yes.
But the temporary chat is not gonna memorize, and you don't have a history of it. Oh, now because I put temporary, it's okay. Again, tell us about
the Golden Week project.
Golden Week
project in NICU.
In NICUs. Okay.
Good.
And here I will put this. You see the word. This is, if I press this one, it becomes live search in the web. If I don't press it, it will use the previous data, which I think now it's reached 2023, the previous data. So it has the knowledge of all the data on the internet up to 2023. If I press this, which I'm gonna do, it's gonna be more updated. But if you notice here, I cannot attach file anymore. If I don't press it, I can attach any file, any picture. I can attach it, but it will upload to the system, to their system. So make sure what you are attaching. Let me put a live, and then I will press, and it's gonna answer me now. It's searching the web. If you can see on the right side, it gave me what the references is going through. And here it started to talk about the key components of Golden Week program, standardized clinical guidelines. And here it's starting to give a reference. Let me double check if this reference is accurate. Yes, it is accurate. Previously, it has a lot of hallucination. So it started to give me a reference. Do you have any other question you want to guide it now?
Inability to walk.
In the children. So a different topic. If a different topic, I'm gonna open a new chat. If the same topic,
someone asked inability to walk. They want to.
Okay, let me go with a new chat. So this is a new chat. What about the inability to talk? Inability to walk. What are the causes of inability to walk? Let's give it more let's say 5 years
old. In pediatrics on the children.
If I ask it, it's gonna be general answer. So the more you specify it in a 5-year-old, 5-year-old child, since.
And after this, another one wanted to know the new treatment for HLH.
Okay, so this is the inability to walk. It gave me, when you give it a general question, it will give you a general answer. You see, it's very fast.
Yes.
Okay, let's ask about, let me ask the same question, inability to walk. Here it's gonna just mention a lot of differential now, because I did not guide it. I just gave it something very vague. And by the way, I use it in some patients, sometimes in complex cases in PICUs. Sometimes, not a lot, but we use it occasionally, and it produces similar to what we discussed it as a team. So let's say the same 5-year-old with inability to walk and HLH. Let me ask it, could it be HLH? Now, because here it's the same chat, it's gonna link it with the history. So here I asked it, could it be? It says yes, HLH could potentially be a cause of inability to walk, though it's rare. It's a rare and serious so it starts to talk with you. This is the beauty of it. And again, look at the word I'm using, it, not he or she, because it talks too much as if it's a human.
Yes,
And
yes.
sometimes I use it when I'm driving the car, because it has like you can use it to talk with you, so it can talk also back with you, so you don't need to look at the screen. So these are
Yes.
just examples. And if I like it, I'll give it a good thumbs up, good response. If I don't like it, I'll tell it why I don't like it. Did not follow the instruction, and it learns from me. Now it's learning, by the way. It's learning from millions of users, millions of answers. So I hope I just gave you a touch about this models.
ده كده هنحتاج دروس خصوصية.
اتفضل.
هنحتاج دروس خصوصية كده، احنا away
ابد
from
ابد، لا لا لا،
احنا
go ahead. Look,
لسه
look,
ما
there's
دخلناش
nothing
المجال
like
ده خالص.
nothing like trial. It's very easy to use, but you have to start using it.
طب هسأل حضرتك حاجة. زمان كان في، لو تفتكر، CD بتاع اوكسفورد، كنا بنجمع عليه الجينيتكس. انا احط الداتا اللي موجودة في البيبي، وهو يحاول يربط اكتر حاجة معاهم ويديني احتمالات. هل ده يقدر يساعدني في كده؟
Of course.
اها.
Let me try this one. Let me try. Can you diagnose genetic disease? I will ask it. If you notice here, they put a small disclaimer at the end. I don't know if you can see it. They put ChatGPT can make mistakes. So they have a disclaimer. يعني مشان يرفع مسؤولية عن نفسهم. But this is a ChatGPT 01 preview. I switched to this is their biggest model. هذا بيقولوا الموديل كأنه PhD student. اعطيني مثلا هنا قال لي thought about it. I cannot diagnose genetic disease, but I can provide general information about them. Genetic disease, blah blah blah. It doesn't want to commit itself to an medical legal. But if you can give me, for example, give me some dysmorphism. What could
يعني for example first day convulsions.
neonate.
A neonate presented with convulsions in the first day.
She has convulsions. Other feature convulsions.
كان في شويه كورس فيتشر، يعني facial dysmorphism.
Facial features. Any other things?
Hypotonia.
Hypotonia. Let's make it more complex. Maybe VSD. I don't know. I'm just VSD and let's say in renal hydronephrosis.
Can we say the finding of MRI, for example, global asphyxia in both salami and brain?
Global asphyxia. I had also and
MRI showed global asphyxia.
MRI showed global asphyxia.
Yes.
Right. Let me just copy this because I'm gonna just show you in the other model how it behaves. So this is now in the ChatGPT 01 preview, which is the highest tech model. It takes time because it starts to analyze it more closely than the ChatGPT 4.0. اللي أول واحد كنا عم نستخدمه هذاك السريع. هذا يبدأ يفكر أكثر، يعني more of a human. So I thought for 16 seconds. And this is what started to give me symptoms you described, blah, 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 may indicate complex medical condition affecting condition and congenital. It just gave me a vague answer. So
لأن الحاجات فيك برضه، ما هو هيقول لك metabolic.
Let me try ask it for DDX, and it understands a lot. Even if you write errors, it will understand what you wrote.
Yes.
I will give you a quick hint. Each word I put in my chat, it becomes like they call it a token. كأنها يعني حاجة كده يعتبرها، يبدأ analyze it. So previously I think we had like 500 tokens، ما نقدر نحط كلام كثير. الآن صارت أكثر، فكل كلمة حرف صغير حرف كبير أحطه سبيس ما في سبيس يعتبرها بميزان القياس تبعه. So I asked it for DDX and it understood what I mean by DDX. It understands I want my differential diagnosis and it starts explaining based on the symptoms you have described, blah, blah, blah. Of course, I added here some additional, حطيت ال VSD, hydronephrosis, and it tries to tell
هو
what
اتلخبط فيه.
Yes,
كده اتلخبط.
ما أنا لخبطته.
أيوه
Let me go with a general model, which is available for free. This is a general. I just switch in the same chat with a general model. Let me try to take away from your patient. There was no VSD and no hydronephrosis. This is what the patient you had. Let me try. What are the most likely diagnosis?
Okay.
Diagnosis. Okay, so I'm just going to give you an example. So this is faster model, and it started to give me
non-ketotic hyperglycemia.
Yeah, mucopolysaccharidosis because of the coarse features, I presume.
Yes.
Congenital disorders of glycosylation, paroxysmal disorders, vigor. So you see,
yes.
yeah, it's more of an open-end source.
Now he went in the right direction.
Yeah, because بالأول أنا لخبطته. أنا حطينا أشياء من عندنا. But it's nice to chat with it, to think about it. I wanted to all colleagues to have it like a co-pilot with you, بس ما يكون الدافع الأساسي. Be careful, it could have صار أحسن من أول. I hope I demonstrated it. I'm gonna stop now.
شكرا جزيلا.
From your time.
I just wanted to congratulate you as your department in the hospital is congratulating you for reaching 100,000 استشهاد على منصة جوجل سكولر. فألف مبروك.
كيف وصلت لك؟ هذه لسه هذه فيري فريش. هذه كيف وصلت
لك؟ ده لسه النهارده.
الله يبارك فيك. ثانك يو فيري ماتش.
النهارده فخدنا الفرصه ان نهنيك زي ما هنوك.
ربي يكرمك. شكرا دكتور نبيل. شكرا يا
دكتور هاني. شكرا جزيلا for being with us. Okay, now we will move to our next speaker. Our next speaker will be Dr. Radwa Al-Qadi. Dr. Radwa Al-Qadi is assistant professor in Cairo University, and she is a consultant, assistant professor of pediatrics, immunology, and allergy. And she is also a consultant in Saudi German Hospital Riyadh for pediatrics and immunology and allergy. Dr. Radwa again will give us a presentation about questioning the immune system when doubt is warranted. تفضلي دكتور رضوى. اهلا بك وشكرا على المشاركه.
اهلا بك دكتور نبيل. شكرا لحضرتك على هذه المشاركه الثمينه. Can you see my slides?
Yes, اعملي بس slide show. Yes, تمام يلا توكل على الله.
السلام عليكم دكتور نبيل. Thank you so much for the valuable invitation. And thank you everyone for the amazing presentation all through the 3 days. Dr. Hani for the amazing AI. Next presentations are all going to be made by AI, inshallah. Okay, so today we are talking about the immune system when doubt is warranted to question the immune system. Back in the past, not really the past, like 10 years ago, when I first started practicing immunology, we used to think about the immune system as this group of heterogeneous monogenic diseases that directly resulted in increasing the susceptibility of the host to infections. As simple as that. They are monogenic diseases causing increased susceptibility to infections. And we used to always say doubt immune deficiency when the patient has any of the SPIR infections. SPIR were short for severe, persistent, unusual, or recurrent SPIR infections. That was our goal. That was our scope. We always used the 10 warning signs leaflet that you could see right here, which all gather around the seriousness and all the unusualness of the infections. The prevalence of immune deficiencies, or the PID as we used to call it, was no more than estimation of 1 per 150,000 births. They were considered rare, very rare diseases, even orphan diseases. The IUIS, or the International Union of Immunological Societies, took over the responsibility of the PIDs from the WHO around the 90s, and it took on its responsibility to update our catalog or our inventory of immune deficiencies every other year in a convention and a paper published every 2 years to try to encompass thinking that that was possible to encompass all the immune deficiencies in order to facilitate for the physicians the diagnosis and the management of those diseases. Unfortunately, 10 years forward, this mission proved to be very difficult, and the field kept growing and growing. And the main reason for that is the development in the molecular diagnosis. The development of the molecular diagnosis opened our eye to the true spectrum of these diseases. No more could we call them the primary immune deficiencies, because as we diagnose the genotypes of these patients with the huge heterogeneity in their phenotype, we discovered that not only it's a susceptibility of the host infections, it's also the autoimmunity, the autoinflammation, atopes, bone marrow defects, increased risk of malignancy. So the concept kept growing more and more, and currently the field of IEI, as we call it now, the inborn errors of immunity, encompasses more than 500 monogenic conditions strictly tied to these phenotypic presentations, and the number keeps growing every year, which makes it even more and more challenging for us immunologists, and as well as the pediatrician and the family doctor to try to pick those diseases from among others. The current prevalence is not really accurate, but it ranges somewhere between 1 to 1,000 to 1 to 5,000, which is a huge difference than the original prevalence we thought about. The most recent classification of the IUI was in the year 2022. The next one should be around the year 2024, and it's usually issued by the end of the year. And forgive me for the next slide, but these are the categories of the immune deficiencies according to the last classification. They are 10 main groups. We are going to go through them very quickly, of course, not all of them. The first group is the combined cellular and humoral immune deficiencies. The second is the combined immune deficiencies with syndromic features. And then we have the predominant antibody deficiencies. And then we have diseases affecting the immune dysregulation, and then congenital defects of phagocytosis. We have the defects in the intrinsic immunity, among others, the autoinflammatory disorders, complement deficiencies, bone marrow failures, and finally the 10th category of the phenocopies of CID. As you see, they are huge. There's a strong effort to include all of them. We sometimes succeed, sometimes we resort to the molecular diagnosis, but the aim here is to raise our clinical index of suspicion in order to reach earlier diagnosis. Because of the shortness of the sessions, I'm not going to go through all of these categories, of course. These are the 10 categories in a better presentation. I'm just going to pick up a few of them with the red flags lighting towards this category in order for us to facilitate the diagnosis, as we said. So the first group would be the combined T and B cell. For me, this is the most important category. We cannot not know about it because it encompasses some of the very, very, very morbid immune deficiencies. The features of the cellular defects usually are that unusual organisms. We should always suspect cellular defect in patients presenting with serious infections by weird organisms, unusual organisms like CMV virus, EBV virus, enteroviruses, fungal infection, very important. Opportunistic infections like pneumocystitis jirovecii, bacteria, unusual bacteria like the Mycobacterium species and the Salmonella species. Certain manifestations should also trigger us, like the GBHD presentations. Infections following vaccinations are very important. Disseminated BCG, paralytic polio after oral polio vaccination. Some cutaneous weird manifestations like warts, molluscum contagiosum recurrent, telangiectasia and ataxia telangiectasia patients. The presence of the susceptibility to infections along with other hematological abnormalities like pancytopenia, thrombocytopenia, and always a positive family history. The laboratories involved in this category, the very useful, the very simple, the cheap CBC. Always remember the CBC, your friend. The CBC is one of the most effective and underused and affordable screening methods. When we report to the CBC, this is usual practice. I always have seen this with the residents that we used to work with in the university, and all junior doctors. They're so fascinated with the total lymphocytic count and then the absolute neutrophilic count. What about the absolute lymphocytic count? It's always been our argument with these doctors, with young doctors. Please do not neglect the absolute lymphocytic count. It's of utmost importance. ANC is important, but ALC is as important, if not more important, in the young pediatric population. After the absolute lymphocytic count, we have the lymphocyte subsets, which categorizes your lymphocytes into the T cells, the T helper, the cytotoxic, the B cells, as well as the natural killers, which will put us into perspective, as we're going to see immediately now. Lymphocyte proliferation assay is the function. If the lymphocyte subset is the counting of the cells, think about the lymphocyte proliferation assay as the function, the assessment of the function of the T cells. Unfortunately, this is not readily available in all labs. And then we have the cytokine assay and, of course, the molecular studies. We'll go ahead to the first case. This young baby was an 11-day-old boy, 11-day-old male from consanguineous parents. He first presented to the NICU with jaundice, with neonatal jaundice at day 1 of 19.5. The patient underwent exchange transfusion, and few days after the exchange transfusion, this occurred. The patient developed pancytopenia, organomegaly, sepsis, direct hyperbilirubinemia, and organ dysfunction, and the patient passed away. This was the patient. All the patients you're going to see are rare patients from the immunology clinic that we have encountered in our practice. Looking back at our baby, a blood sample was taken, and because of the stormy presentation, the lymphocyte subsets were done, and retrograde after the death of the baby, we saw these results. There is CD3 lymphopenia, there is T helper lymphopenia, there is cytotoxic lymphopenia, as well as B cell. All the parameters are stormy. They are very clear. There is no doubt about having absolute lymphopenia affecting all the subsets of the lymphocytes. And this is definitely the diagnosis of SCID. Most of us now know what is SCID. SCID is the severe combined immune deficiency. It is on the high end of the spectrum of the combined T and B cellular affection. In this baby, the molecular study also showed that he had a homozygous RAG1 deficiency. The next baby, not less in the stormy presentation, the next baby, he had this very unusual family history, a very strong consanguinity in the family. He had a SIB who died at the age of 5 months after following attacks of pneumonia and diarrhea. Lymphopenia, as we can see, as well as leukopenia and lymphopenia. Another baby, a boy who died, and we didn't have documents about. Another baby girl who died at the age of 3 months. Again, the same picture: thrombocytopenia, leukopenia, lymphopenia. And our baby was no different. He presented with long history of oral thrush, diaper rashes, which are all candidal and fungal infections, as well as large pulmonary ulcers and recurrent attacks of pneumonia and diarrhea. Look at this family history and see and gaze upon the importance of taking a family history. The whole family had similar conditions. In the cousins, again, death, early death, recurrent infections, very clear. And his blood count again showed crystal clear deficiency of the lymphocytes as well as the subsets. No doubt there about the diagnosis. It was a T negative, B negative, NK positive SCID resulting from homozygous RAG1 deficiency as well. Severe combined immune deficiency, as we just said, is a medical emergency. Why is it a medical emergency? Because the baby typically presents normal at birth. There is no affection in the first few weeks or first few days, and then the baby starts to accumulate serious morbid infections by opportunistic organisms like pneumocystitis, cerevisiae, or candidiasis, and then succumbs within the first 2 years. And by the time that the baby starts to manifest, there is no, you have lost your window. You have lost your golden window in time for intervention and management. So in these cases, the babies should be managed before the presentation. And here comes the importance of the neonatal screening. Neonatal screening was added to the compulsory screening programs in many of the Western countries, including the USA, and even my MD thesis was about neonatal screening. It's a beautiful tool that can pick up these babies way before the presentation of the symptoms. SCID, always remember, always remember, avoid live attenuated vaccines and avoid the transfusion of blood or blood products if they're not irradiated. Major cause of mortality, because once that's done, and we have seen a lot of cases like that, we diagnose early, but do you know what? The baby is CMV positive because he had a prior blood transfusion, and there goes his window for the bone marrow transplantation. So always, if in doubt, perform irradiation for the blood products and withhold the live attenuated vaccines. These babies usually receive antimicrobial treatment, antimicrobial prophylaxis, immunoglobulin transfusion as a preparation for the only therapeutic treatment, which is the immune reconstitution with a bone marrow transplantation. For the ease of the nomenclature, these diseases, the SCID, were named according to the presence or absence of the T, B, and NK cells. So there, in the two examples we just saw, they were T negative, B negative, NK positive. And this nomenclature eases the genotyping of the babies until the molecular results are available. So if the baby is T negative, B negative, NK positive, we readily know that could be a RAG1 or a RAG2 deficiency, and this affects the treatment and affects the prognosis. There is one, before leaving SCID, there's one type of SCID, of severe combined immunodeficiency, that I would like to shed some light upon, which is the leaky SCID, or the hypomorphic SCID. If you see here, this kind of SCID has a T positive, B positive, NK positive immune phenotype. So this is caused by any affection of one of the genes causing SCID if that mutation resulted in hypomorphic mutation, resulted in the production of a small amount of the protein rather than the null mutation that would result in SCID. So if the patient has a null mutation in the RAG, for instance, in the RAG or in the common gamma chain gene, he would be a SCID baby. But if there is little production of the protein, it's not a null, it's a hypomorphic, he will be an omen. And why do I keep talking about this phenotype? Because this leaky SCID or this hypomorphic SCID really confuses us with other differential diagnoses. This baby typically presents as in this picture, this baby, another baby from our clinic, he presented at the age of 4 months with what you could see here, the exfoliative dermatitis, severe, covering him from head to toe, everywhere. He had alopecia totalis, as you could see in the picture, intractable diarrhea, failure to thrive, recurrent infections, pneumonias, diarrhea, not severe enough to kill him yet. However, there are the infections, and also there was organomegaly and lymph node enlargement. This is the typical presentation of the Omen syndrome. Omen syndrome typically presents like this. Once we do the blood work, there will be your answer, and you will also find an affection, but not as severe as the severe combined immunodeficiency baby. You will find some residual leukocytes, you will find some lymphocytes, you will even find increase in a certain group of lymphocytes like this, the T cytotoxic cells, or you'll find eosinophilia, you will find some residual immunoglobulins. This is due to the oligoclonal expansion of the lymphocytes, and hence the result of autoimmune manifestations like the dermatitis and the enteropathy. Again, why do we mention those? This is a cohort, this is paper published from our clinic at Cairo University, depicting 31 RAG babies, RAG1 and RAG2, some of them, like 20% of them, presented as Omen syndrome, while the rest presented as severe combined immunodeficiency. These babies, as I told you before, easily confused with atopic dermatitis, seborrheic dermatitis, and this confusion, again, makes us lose the golden window of time, because these babies keep getting treated by topical steroids and antihistaminics as if they are atopic dermatitis or seborrheic dermatitis. And this is one of the babies that presented in our Saudi German hospital clinic, as the mother thought he was the opposite. The mother thought he had an immune effect, but after examining him, this was atopic dermatitis. And you can see the similarity in the phenotype, and hence the cause of the confusion. This coincides the combined. Now, another case from the other category, the combined with the syndromic features. This boy was a 3-year-old boy, negative consanguinity this time. As a baby, he suffers from jaundice and sepsis and had NICU admission, and then started to manifest from recurrent bleeding tendencies. He even didn't have his circumcision due to that. Always have ecchymotic patches, finally being diagnosed as ITP. The baby also suffered from recurrent attacks of bloody diarrhea and diagnosed as IBD. He had recurrent infections of the upper airway, recurrent otitis, sinusitis, and by examination, there was nothing more than the ecchymosis and the petechiae, as well as the upper airway infections, and also there was atopic dermatitis. Lab of this baby showed nothing other than thrombocytopenia. However, this was associated with a very important finding, a small mean platelet volume. So this is not just thrombocytopenia, this is micro thrombocytopenia. Okay, microthrombocytopenia, or a small MPV in a male baby with ITP, is a good place to start to doubt the Wiskott-Aldrich syndrome. And this baby ended up, we did a protein expression for Wiskott-Aldrich syndrome protein by the flow cytometry, and he proved to be deficient in the Wiskott-Aldrich syndrome protein. WASP, or Wiskott-Aldrich syndrome protein, is a key regulator in the hematopoietic cells. It's a cytoskeleton regulator, which means that it forms the skeleton of the hematopoietic cell part. It's one of the proteins forming the skeleton, as we see here in this picture, of the hematopoietic cells, lymphocytes, antigen-presenting cells, even the neutrophils. This cytoskeleton is essential for the cellular locomotion and for the cell being able to mount an immune response, for the movement of the cell, for the movement of the invagination and the phagocytosis, for the movement of the intracellular bodies that would lead to the phagocytosis and intracellular killing. All of these require an intact WASP. WASP is one, actually, of a long list of proteins that was recently diagnosed, like ARP-CP1 and like DOC8 protein. All these proteins have the similar function of the actin cytoskeleton formation, which allows the phagocyte to move and hence function and do its function in the immune system. And because this protein is essential for the phagocytes and neutrophils and lymphocytes, as well as the other blood cells, these patients present with thrombocytopenia, neutropenia, as well as other autoimmune manifestations. The classic triad of Wiskott-Aldrich syndrome, as we just said, is the triad of recurrent sinopulmonary bacterial infections, eczema, and bleeding tendency. There is also the autoimmune diseases, could be arthritis, nephritis, autoimmune hemolytic anemia, and there's also predisposition to malignancies. And this was, these are two of our babies presenting with WASP in the clinic. You could appreciate in the pictures the ecchymotic patches, the petechiae, the dermatitis, the atopic dermatitis. Again, a lot of these babies lose a lot of time being treated as atopic dermatitis babies. So always think about it. Any boy presenting with ITP that's proven resistant to treatment, accompanied with any of these, just do a CBC, a simple CBC with an MPV that would show you the size of the platelet, would take you readily to the diagnosis and saving the life. Of course, Wiskott-Aldrich is a combined immune deficiency and only treated by immune reconstitution with the bone marrow transplantation. These patients don't die from the immune deficiency. Unfortunately, they die from bleeding, and they have proven to be super difficult in their management. We always used to manage them with the hematologists hand in hand, and they received a lot of platelet transfusion, blood transfusion, even Eltrombopac, which is the thrombopoietin agonist, in order to raise their platelet count. The main death cause here is the bleeding tendency rather than the immune deficiency. Jumping to the next category, we're going to talk about the predominant antibody deficiency. Antibody deficiency has been written in the literature as being the most common type of PID. However, we always have to remember that the literature was written mainly by Western countries.
approaching the time. يعني try to لسه كل ده ال10
مش كلهم. Okay, we're going to go faster. Okay, so antibody deficiencies, as I said, they are common in the Western countries due to the autosomal recessive. In our countries, no, they are not as common. The categories include very mild diseases like simple IgA deficiency or transient hypogamma of the newborn, up to the other end of the spectrum with common variable immune deficiency or A-gamma globulinemia. The very, very, very important finding, don't ever forget about the lung diseases. In any patient presenting with chronic illness in the lung, early bronchiectasis, early interstitial lung disease, unexplained, recurrent sinopulmonary infection, always consider the antibody deficiency. These patients are very susceptible to the virus, to the enteroviruses. And oral polio vaccine in these patients equals acute flaccid paralysis. That's why oral polio has been deferred in many countries, including Saudi Arabia, to the age of 6 months instead of 2 months. Jumping to the next category is the congenital defects of phagocytosis. Very few words about it. Defect in phagocytosis either affect the number of phagocytes or the function of the phagocytes. In this example, we're going to talk about the function. This is a baby boy, consanguineous family again, presenting with this very peculiar omphalitis early in life, delayed separation of the umbilical stump, very important sign, hallmark of the disease. You could see here the omphalitis. You could see, and in this picture as well, the omphalitis here and there, the very, very annoying, non-healing ulcers that are specifically for one thing. They have no pus. There is no pus. So remember this, if there's a baby presenting with recurrent soft tissue infections, getting worse by the day, not responding to treatment, getting deeper and bigger with no pus, cold ulcers, always think about this disease. Delayed separation of the stump, omphalitis, cold ulcers, among other deeply seated infections like otitis, and this patient eventually was diagnosed by doing as a LAD patient. LAD patient or leukocyte adhesion defect is a group of diseases characterized by the defect, the inability of the lymphocytes or of the phagocytes to roll down the vascular membrane and adhere and activate and do transendothelial migration. So the lymphocytes, in response to infection, they keep proliferating, and they never reach the site of the infection. That's why there is no pus at the site of the infection. And that's, again, why this disease is characterized by very, very large number of neutrophils. You will find this patient easily with a CBC. The TLC could be as big as 40,000 or 50,000. A simple test of CD11 or CD18 by the flow cytometry would diagnose the case. The autoinflammatory diseases is another group. think about it, the autoinflammatory, autoimmune. Autoimmune is the unchecked activation of the acquired immune system, while the autoinflammatory group is the unchecked proliferation of the innate immune system. The flagship of this category is the FMF. FMF should be always sought in all patients presenting with unusual fever, recurrent abdominal pain, arthritis, vasculitis. Always keep a high level of suspicion in patients originating from the Mediterranean. I have a patient referred here in the clinic that was diagnosed as septic arthritis and went into operation and had synovectomy and open surgery, and then referred to me as septic arthritis, who proved to be FMF and doing now beautifully on colchicine and growing well. So always remember the FMF with the unusual presentation. The next and the final category, for the sake of time, is going to be the complement deficiency. Always underrated, the complement system. Everybody hates it. We're going to go through it very quickly. The complement system has many functions of the immune system, opsonization, and the anaphylatoxins of the complement system causes the vasodilatation and the chemotaxis, initiating an inflammation, which eventually is directed towards fighting the organisms. In order for the complement system to do its function, there has to be a regulation of its activation, because its functions are all revolving around inducing inflammation, vasodilatation, and other types of inflammation. Okay, so that one of the components of the regulation of the complement system is the C1 esterase. C1 esterase, as well as the C3b and the DAF, are proteins, are like plugs that stop the activation of the complement system and hence stop the cascade of cytokines. In this case, this very unfortunate girl, Malak, has been presenting with recurrent abdominal pain, recurrent swellings in different parts of the body in response to the minor trauma or minor stress. Her family history is morbid. Her family history is very scary. She had a grandfather and a grandmother dying from suffocation, from laryngeal edema, from the same disease that she has. All her family, although this is a non-consanguineous family because this is an autosomal dominant disease, all these members in her family also manifested with the same attacks. This patient was about to die many times because of the laryngeal edema and the asphyxia. Of course, this patient has C1 inhibitor deficiency. As we just said, C1 inhibitor is a plug for the complement system activation, a clock stop for the complement system activation. The disease is autosomal dominant. That's why the whole family has negative consanguinity. It's due to the mutation in SERPING1 gene, and it leads to the chronic unchecked activation of the immune system, producing the angioedema. As we just said, the angioedema could manifest as edema of the limbs, could manifest as non-specific abdominal pain, vomiting. It's incredibly disrupting of the patient's lifestyle. You have no idea about the pain these patients suffer. I was responsible for the group of the angioedema back in the clinic at Cairo University, and it's hell. I can tell you it's hell. Whenever they have an exam, whenever she has any small fight, any distress, she would puff like a balloon, and she was at clear risk of death from suffocation. The diagnosis is simple, it's easy, it's just the estimation of the C1 esterase level and function. And I wanted to bring up this case because, as I told you, these are the possible triggers, the probable triggers, and the management is by the C1 inhibitor treatment. I wanted to mention this case because there's a confusion in the clinical practice between urticaria and angioedema. We should always differentiate. The patients on my left side are some of the cohort of the patients I'm following up at Cairo University. They are all patients diagnosed with hereditary angioedema. Actually, this is Iyad. He is Malak's brother, and this is Karma. They all have the same nasty attacks. On the right side, you're going to find a total different presentation. This is one of the patients we're following up at Saudi German Hospital Clinic. He has chronic idiopathic urticaria. You could appreciate the difference between the hives and the wheals in this patient. Again, a nasty disease disrupting daily life. However, they could present with facial edema and laryngeal as well. As you can see, some episodes had that. How can we differentiate clinically? These patients usually don't have itch, Antihistaminic and steroids don't have any effect on their condition, to the contrary of the chronic urticaria patients, where the antihistaminics cause some improvement. Of course, this patient didn't improve on anything, not antihistaminics, not Xolair. He improved only on Dupixent recently. Marvelous improvement. So to summarize, I'm sorry if I took so much of your time. We don't want to be here. We don't want to diagnose our patients at this stage, after they symptomatize, after it's too late. We want to be more there. We want to be towards the neonatal screening and the antenatal screening and the focused screening of the patients in order to give them the treatment they need at the right time. The take-home messages, IEIs are a heterogeneous group of phenotypes of diseases. They necessitate a high clinical index of suspicion. And whenever we find a patient presenting with spore infections or lymphoproliferation or immune dysregulation, it warrants the workup. Infectious history, family history, super important and saves lives. A simple CBC and immunoglobulins could lead us towards the diagnosis, and molecular diagnosis, of course, is very important in these patients. Thank you so much for your time, and have the best of luck.
Thank you so much, Professor Radwa. Really, it was amazing lecture, and the next time, inshallah, we'll give you 1 hour. And if it is like this, actually, many were writing to us, let her to complete. We'll give you more time, but next time we can give you 1 hour. Thank you so much for your participation and for your excellent lecture. And inshallah, next time we'll take more lectures from you. So we'll now move to our next speaker. Our next speaker will be Dr. Latifa Al-Mahmoudi. Dr. Latifa Al-Mahmoudi is a senior consultant neonatologist in King Saud Medical City, Al-Shamisi Hospital in Riyadh. Dr. Latifa is one of the figures of the NICU care and accreditation in the Saudi Council and the Saudi Emirates. So Dr. Latifa will give us now a lecture about necrotizing enterocolitis, prevention and management. Dr. Latifa, you can start your share.
السلام عليكم.
وعليكم السلام ورحمة الله وبركاته.
جميل على الاستضافة وعلى الكلام الجميل. الله يعطيك العافية. أنا حكون سريعة أسرع من الدكتورة رضوى إن شاء الله. I will talk about necrotizing enterocolitis, prevention in the newborn. Necrotizing enterocolitis, as we know, is severe inflammatory gastrointestinal disease predominantly affecting preterm infants, and it is characterized by intestinal necrosis and subsequently perforation and systemic complication. And the incidence is about 5 to 7% in infant born below 32 weeks of gestation. And globally, the incidence is increasing because of increasing the survival of extreme preterms. And as we know that NIC usually increase the morbidity and mortality, increasing the longer, increase the hospital stay in the for the babies, and impair neurodevelopmental outcome. And it also affects the healthcare cost as burden. The pathophysiology of NIC is multifactorial, and it's arising from a complex of dysbiosis, intestinal injury, and immune activation. Dysbiosis is an imbalance in the gut microbiota, in which the harmful bacteria dominate over the beneficial ones, and usually the preterm infants have less diverse gut microbiota, and the pathobionates such as Enterobacter and Clostridia are commonly implicated in the disease. And usually dysbiosis is detected in the babies and predispose them to necrotizing enterocolitis. The intestinal injury is reducing the caused by intestinal injury caused reduced gut perfusion, bacterial toxin, and metabolites. They damage the gut layers, and formula feeding also increase the bacterial overgrowth, and also the lack of protective components found in the breast milk, like human milk oligosaccharides and immunoglobulin A, also play a role in the intestinal injury. Overuse or antibiotic use also disrupt the microbial balance and foster the pathogenic dominance of injury, and lead to weakened the intestinal barrier and increased permeability and bacterial invasion. There is immune activation and inflammation, as the compromised gut barrier enables bacteria to enter the bloodstream. This will activate the tool-like receptors, which trigger inflammatory mediators, and subsequently inflammations, which increase the gut injury and lead to systemic inflammatory response. There is a risk factor predisposing the babies to NIC. In preterm babies, there is a GI system immaturity, and there is immature immune defense, and there is also aggressive, sometimes aggressive enteral feeding, presence of patent ductus arteriosus, and management of BDA with indomethacin, mucosal injury due to hypoxic ischemic insult, and presence of bacteria with GI lumen, and overcrowdedness, which lead to decrease the infection control measurements and spread also the infections. In term baby, usually congenital heart disease and other disease like hypothyroidism, Down syndrome, and bowel atresia, gastroschisis predispose full-term babies to NIC. Polycythemia and condition where oxygenation and blood flow impaired is also a factor. Exchange transfusion and prenatal stress and aggressive also enteral feeding predispose babies to NIC. The laboratory investigation, usually we are doing the routine investigation, the CBC, and sometimes we'll find leukocytosis or leukopenia, which suggests infection. Thrombocytopenia is common also in NIC, and due to consumption of platelets in the inflammatory process. C-reactive protein is a marker which is elevated in infection and inflammation, and we use it also to measure, to monitor the progression of the disease. And blood gas analysis, there will be sometimes metabolic acidosis, and the presence of metabolic acidosis is just ischemia or shock status in the baby. Lactate level may be elevated due to tissue hypoxia. Blood culture will show the bacteria in some cases, and the commonest is E. coli, Klebsiella, and Clostridium. The electrolytes hyponatremia is common in babies with NIC, and it's due to third space fluid loss and bowel injury. And the hydration status of the baby should be also monitored and managed accordingly. The coagulation should be monitored, and if there is decrease in fibrinogen levels, this may indicate DIC or severe complication. We can see also the occult blood in the stool, or sometimes visible blood. Radiological investigation, abdominal X-ray, which can show pneumatosis intestinalis or portal vein venous gas, or free in intraperitoneal air as perforation is there. Dilated loop bowel indicating bowel stasis or obstruction, or fixed loop indicating resistant dilated bowel and indicating ischemia of the bowel. And we need to monitor by serial X-rays taken every 6 to 12 hours to monitor the progress of the disease. Ultrasound is also used to complement the X-ray findings, and it is usually sensitive, detecting portal venous gas, and also detecting free fluid, which may indicate perforation, and it can show the wall also thickness and the bowel perfusion. Ultrasound is especially useful when there is high clinical suspicion of neck, but the X-ray are inconclusive. Contrast study can be used, but it's rarely used due to the risk of perforation. It helps in differentiation neck from other conditions like volvulus or malrotation. In the X-ray, you can see the X-ray in the right, the pneumatosis intestinalis. And in the second X-ray, we can see the portal vein in the liver, and the third X-ray showing perforation and free air in the abdomen. The diagnostic definition of neck, actually there is no universal accepted diagnostic definition, and because of many similar conditions can mimic or present like neck. Spontaneous intestinal perforation, sepsis, can present like neck and may have the same, sometimes the same picture, but usually in spontaneous intestinal perforation, they usually lack pneumatosis intestinalis or portal venous gas on X-ray, and usually they present earlier in the first or second week, and usually it is associated with factors like steroids or indomethacin. The traditional definition used is Bell staging and its modification, which focus on clinical severity and radiological evidence. As we know, that when it is suspected, there is no radiological finding and the intestinal size is absent or mild. In the second stage, there will be pneumatosis in stage 2A, and in stage B, there will be extensive pneumatosis. In stage 3, there will be marked respiratory and metabolic acidosis, mechanical ventilation, and hypotension, deterioration in the clinical features with worsening wall edema, and there will be ascites in the prominent ascites and the resistant bowel loop, and there is no perforation yet. In third stage, there will be pneumoperitoneum, third B. There is another new diagnostic definition emerging now, depending on clinical features and radiological feature, plus surgical and pathological finding, like a Fairmont Oxford network definition. This is the most definition used, and it's help in standardize the diagnosis of necrotizing enterocolitis. There is also International Neonatal Consortium definition and UK gestational age specific case definition, which is a point-based system considering gestational age for diagnosis and to improve the specificity of the score. There is another definition. All need to be explained, but there's no time. I will take one of them is Fairmont Oxford network definition. It's used clinical and radiological criteria, and it excludes spontaneous intestinal perforation. And this definition represents a case step toward standardizing neck diagnosis and improving care quality. It's widely used globally over than 1,500 hospital using it, and it is benchmarking for the outcome across neonatal units. It decreases the overdiagnosis from non-specific symptoms, so decreasing the NIC incidence reporting in the United States from 7.1 to 5.2. The negative things about the Fairmont Oxford network definition is that the earlier stage of NIC may not meet the criteria, so this may lead to delayed diagnosis. The Fairmont Oxford network it uses clinical signs, and there should be at least one of them required for diagnosis. These clinical signs is bullous gastric aspirate or emesis, abdominal distension, or occult or gross blood in the stool. Radiological finding, at least one of them should be there, pneumatosis intestinalis, portal venous gas, or pneumoperitoneum, and there should be surgical or postpartum confirmation of NIC, and they exclude spontaneous intestinal perforation. So it needs to be confirmed by surgery or postpartum to diagnose NIC. How to prevent NIC, or how we can help to decrease the NIC incidence. There is a care bundle approach has been recently emerging as an effective preventive strategy. It combines multiple evidence-based intervention, reducing the risk of NIC in neonates, particularly preterm babies, and provide essential protection for the immature guts of the neonate. The key components of such a bundle is antenatal steroids, delayed cord clamping, exclusive use of mother's own milk or human milk, oral colostrum care, and standardized feeding guidelines, antibiotic stewardship, reducing use of proton pump inhibitors and H2 blockers, probiotics, and prevention of severe anemia. As we know that antenatal corticosteroids accelerate the structural maturation of the intestinal mucosa, which strengthen the gut barriers and decrease bacterial translocation and improve the survival and health outcome for preterm neonates. And a recent Cochrane review highlights that the antenatal corticosteroid reduced the incidence of several complications, RDS, intracranial hemorrhage, and neonatal death, and to a lesser extent NIC, necrotizing enterocolitis. Delayed cord clamping, as it is improving the oxygenation and blood flow of the gut, increasing the perfusion and decrease the risk of ischemia. It improves the hemodynamic status of the baby and prevent hypovolemia, and prevent fluctuation of cardiac output, decrease the risk of anemia and the need of blood transfusion. So it is decreasing incidence of NIC and IVH. And WHO and ACOG recommend delayed cord clamping for preterm infants to improve outcome, including necrotizing enterocolitis incidence. Promoting breastfeeding, exclusive breast milk feeding is the gold standard for feeding preterm infants. It has protective factors, as we mentioned, hemoglobin A and human milk oligosaccharides, lactoferrin, and growth factors, reduce the risk of microbial dysbiosis and promote gut integrity. Use of donor human milk if the milk of the mother is not available. It should be pasteurized, and it's preferable to formula. Early trophic feeding, small volume feeds of breast milk stimulate the gut maturation, and it will not overload the intestine. The oral colostrum care, it is rich in protein, immunoglobulin, minerals, and fat solubles, vitamins, which make it potent immune booster. For extreme preterm infants who may not have access to sufficient colostrum for feeding, using colostrum for oral care or buccal colostrum has shown promising in preventing necrotizing enterocolitis. And there is a lot of studies. They confirm that the effect of breast milk in reducing NIC is dose dependent. For every 100 ml per kg, there is increase in human. For every 100 ml per kg increase in human milk feeding, there is in the first week of life, there is a decrease in the risk of NIC, and also for the risk of death. And infant born 30-weeker, below 30-weeker, and they are in exclusive human milk feedings and human milk-based fortifiers, there will be decrease in NIC incidence from 19 to 0.5 to 6%. And there was a systemic review showed that using human milk fortifiers significantly decrease the risk of NIC stage 2 compared to formula fortifiers. There's also studies show that reduction of surgical NIC in infants receiving donor milk fortified with the human milk based fortifier compared to those formula. And also they found that NIC was 6 to 10 times more frequent in formula-fed infants compared to those exclusively in human milk. In another meta-analysis of randomized control trials, they demonstrate that oral colostrum therapy increase immunoglobulin A levels and decrease the NIC incidence. And in other meta-analysis showed that buccal application of colostrums could help and prevent NIC, but we need more study to emphasize this issue. Enteral feeding practice by standardizing standardized enteral feeding protocols also improve nutritional care and significantly decrease incidence of NIC in preterm infants. And they found that institutions with the standardized feeding guidelines and protocols report lower incidence of NIC. And in a systemic review of 15 observational studies, they show that standardized feeding protocol significantly decreased NIC incidence. It usually showing gradual advancement, and there is the advice to avoid hyperosmolar feeds and monitoring of tolerance of the baby. Feeding with abnormal Dopplers in babies with absent reversal of diastolic flow in utero. Those babies have compromised intestinal circulation, and the risk of NIC is high. In ADABT trial, randomized infant to early or late feeding initiation and found no significant difference in NIC or sepsis incidence. So minimal enteral nutrition is recommended for all preterm infants with abnormal Doppler. Feeding with patent ductus arteriosus, we know that hemodynamically significant PDA pose a challenge for feeding preterm babies because of decreasing mesenteric perfusion and increased risk of NIC. Also, the pharmacological treatment of PDA by indomethacin and ibuprofen and acetaminophen can lead to gastrointestinal side effects, but the study showed that infants fed trophic feeds during this treatment had better feeding outcome without increasing the NIC risk. Though the evidence whether to feed the babies with PDA should be continued or withheld during treatment is still controversial. Transfusion associated with NIC this is usually occur within the 48 hours of blood transfusion, and there is inconclusive clinical evidence between blood transfusion and NIC. And the feeder trial found no significant difference in outcome, whether feeding continues or withheld or restricted. So continuing minimal enteral nutrition during transfusion is recommended until more conclusive evidence is available. There is a large trial under investigation, and we are waiting for this result or recommendation. Prevention of intestinal dysbiosis, this is important and is critical in reducing the risk of NIC through antibiotic stewardship and avoidance of H2 receptors antagonists and proton pump inhibitors, and initiation of probiotics. Antibiotic stewardship in preterm infants, they are liable to infection, and usually we are using antibiotics too much on this group of patients, and the overuse of antibiotic can disrupt the gut flora and increase the risk of NIC, sepsis, and fungal infection. And prolonged empirical antibiotic use more than 4 days increase rate of NIC and mortality, as shown by the study of Cotton et al. There's also another several study found no role of routine prophylactic antibiotics in preventing NIC. And antimicrobial stewardship program endorsed by the CDC focus on reducing unnecessary antibiotic use in the NICU. And there is a multi-center study reported 34% reduction in antibiotic use after implementation of stewardship guidelines, also, and decrease rate of NIC. Avoidance of H2 receptors antagonists and protein pump inhibitors, because it's increased the gastric pH and change the intestinal flora. Lead to gastrointestinal infection, especially from gram-negative bacteria. It also increased the intestinal motility and contractility, predisposing infant to necrotizing enterocolitis. There's a study reported significant increased risk, 6.6-fold in case of H2 blockers, and there is a systemic review of 3 observational study confirmed the association between these medication and heightened risk of necrotizing enterocolitis. Probiotics are live microorganisms, help balance the gut flora and prevent dysbiosis, which is a risk factor for NIC and late onset sepsis in very low birth weight infants. And they found in the study that probiotics improve immunity, inflammation control, and gut barrier function, and in intestinal dysbiosis, and significantly reduce necrotizing enterocolitis. And in a Cochrane review, they reported that probiotics may reduce NIC risk and mortality slightly. Also, meta-analysis of 77,000 infants from 30 non-randomized control trials found that routine probiotic supplementation reduced NIC more than stage 2, especially in extreme low birth weight infants. The multi-strain probiotics were more effective than single strain. And in a meta-analysis of 106 trials, they found that mixed strain probiotics, particularly in combination with prebiotics and lactoferrin, were the most effective for reducing mortality and severe necrotizing enterocolitis. They found that in tropical region, gram-negative bacteria like E. coli and Klebsiella are more common in neonatal sepsis, while in temperate region, gram-positive organisms dominate. So a specific evaluation of probiotics in tropical climates are necessary. The SBGN in 2023 recommends Lactobacillus ramonas, or a combination of P. infantis, P. lactis, and S. thermophilus use to prevent NIC in preterm infants. And the American Gastroenterological Association in 2020 recommends to prevent NIC preterm baby to use Lactobacillus species and Bifidobacterium species. Anemia is also a predisposing factor for necrotizing enterocolitis, and it is extremely common in preterm infants and increase the severity of NIC, like intestinal damage, with extent of injury being related to the degree and duration of the anemia. So the management is critical, particularly in preventing NIC and related complication. We need to optimize hemoglobin threshold for transfusion, delayed cord clamping, minimize loss from phlebotomy, and provide iron supplementation. The enteral iron supplementation is recommended to prevent iron deficiency anemia and to reduce the need for blood transfusion. The SBGN guidelines the SBGN guidelines recommend for preterm baby to receive 2 to 3 milligram per kg of elemental iron daily once they are on full enteral feeding. Infection prevention is also important. Hand hygiene, central line management, as the NICU with REPOST are implementing infection control protocols, report lower incidence of NIC and sepsis. We should avoid high-risk intervention by minimizing transfusion, avoid excessive red blood cell transfusion, avoid overfeeding, because overfeeding can exacerbate intestinal stress and predispose to NIC. Non-nutritive strategy, kangaroo care as skin-to-skin contact, improve neonatal stability, promote breastfeeding, and enhance gut function. Also, we still recommend gentle handling to reduce stress, which can impact gut perfusion and overall health. Medical management of NIC, as we know, we'll keep the patient's MBO, we'll start IV fluid, and total parenteral nutrition, antibiotics, empirical broad-spectrum antibiotics, usually ampicillin, gentamicin, and metronidazole to provide anaerobic coverage. And the duration is 7 to 10 days if perforation is absent or clinical signs improve, and it can be extended in case of complication or perforation or sepsis. We should give pain management and minimize handling, provide respiratory support and cardiovascular support as needed, and continuous monitoring, and also abdominal exam frequently to check the increasing in distension, tenderness, discoloration, or erythema, blood work and CBC electrolytes to monitor or correct any abnormality, and serial X-ray to monitor the finding of necrotizing enterocolitis. Surgery referral in case of evidence of intestinal perforation, pneumoperitoneum in the X-ray, or severe or worsening clinical status despite medical management, or presence of abdominal mass indicating necrosis or abscess. Operating too early can increase risk, morbidity, and mortality. So we need a watchful waiting approach with frequent imaging, and clinical assessment is often recommended for borderline cases until surgery is indicated. The surgical management, either by primary peritoneal drainage, by placing a drain into the peritoneal cavity to manage the perforation without a full laparotomy, and this is used in very low birth weight infants or critical cases. Laparotomy remain the gold standard for neck with perforation. And in laparotomy, there is removal of necrotic bowel segment and creation of a stoma to divert the feces away from the damaged bowel. But we have to weigh the risk of extensive resection, especially in very low birth weight infant who may not tolerate significant bowel loss. Resection with primary anastomosis. Generally, this is reserved for infants with more stable cases of neck and a clear limited area of necrosis. Second look, laparotomy. This is approach involve performing a follow-up surgery within 24 to 48 hours to evaluate bowel viability after initial resection, allowing for more conservative resection in the first surgery. Laparoscopy is still under study and not yet approved. Thank you so much. I hope I, inshallah, finish in time.
Thank you so much, Dr. Latifa, for your nice presentation. It was excellent presentation. We'll move now to our next speaker, will be Dr. Abdelhakim Al-Utay. Abdelhakim Al-Utay is a consultant pediatric urology in Prince Sultan Military Hospital, and he is the head of pediatric urology division. And he is a member of the American Association of Pediatric Urology. Dr. Abdelhakim will speak to us about ambiguous genitalia, congenital adrenal hyperplasia as an example. Okay, Dr. Abdelhakim, thank you. Dr. Abdelhakim, you are with us?
نعم معك، بس احاول اسوي شير سكرين بس ثواني.
تمام كده، توكل على الله.
طيب، بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Good evening, everyone. Today is I choose this topic because this topic is it seems to be advanced in the beginning, but when you dig on the stories happening now in the society and in the social media, you will see many things talking about the same topics, but it comes in another form of this topic. So I found this special topic is appropriate to be presented today. And as you know, ambiguous genitalia is making a big problem usually for in the nursing area, also in ICU, also in the newborn, especially if we have cases which is like ambiguous genitalia. So today I choose this. This is the most common things we can see, like boys raised as girls and girls raised as boys. So this make a lot of confusion, and I found this one is very important to be careful with, especially with the picture I will show you now. With you cannot say this is a different gender, but in reality it is a different. So we will talk about the common urogenital sinus, clitoromegaly, fusion of the labia majora, and absence of the minora. So as you can see here, this is a brief anatomical anatomical explanation of what's going on. And if you see on the left side, you can see here is the bladder and here is the genital tract, and it's going and communicating in one channel instead of two channel. And this is what we call the common urogenital sinus. It can comes with CIH, with congenital endocrine hyperplasia, or it can comes as isolated without any background syndromes. You can see as this picture, this is picture like of one of the CIH patient with abnormal and ambiguous genitalia. Also, this is another girl with this picture, and this is the initial presentation. And you can see here also, this is like something extra information. This animal is normally is having a common urogenital sinus, and this is where most of the research is done on this animal. So it make it easier for the researchers to go through the common urogenital sinus. As you can see here, this is one of the picture. The urogenital sinus is abnormalities as most often seen in disorder of sexual differentiation, most commonly associated, as we said, with the CIH, has been noted to have an incidence as high as 1 in every 500 births. And clinical presentation, usually they can come with different presentation, either with mild form or with very severe form, with the pictures we can see here, like with the single perineal opening and with the webbing of the scrotal folds. And you can see here as well as another presentation of mild form, but when you see here, you can see there is only a single perineal opening. But unfortunately, this is a girl which was repaired before. So the majority of children born with urogenital sinus have a genital ambiguity, and this should be initially evaluated by the gender assignment team before discharge from the hospital. And the tools of anatomical assessment is a clinical examination. Then after that, you proceed for the radiological imaging in form of ultrasound and genitogram and endoscopies. You can see in the ultrasound, you will see there is a two sac above each other, which all filled with fluid, one filled with the mucus and one filled with the urine. And this one will present. Also, if you do a genitogram with the contrast, you can see there is, you can see on the left side, this is a common channel. And when it comes in the middle, it just go in two ways, one to the bladder and one for the genital, and they are just sharing the same common sinus. Instead of normally going in two parallel channels, they are sharing the same channel, and that's what we call it common urogenital sinus. Also, if you do a cystoscopy, you will go through a single perineal opening. In the middle, you will see there is a urethra, and this is the genital tract. You will see that's going up and down, but they are sharing the rest of the canal. So it has different type, low and intermediate and high. There is multiple definition, American definition and European Society definition by 3.5 centimeter or more than 4 centimeter, which I mean the channel length, because the channel length going with a small channel length, this is a low type, and this one is intermediate, and this one is very high, which is very long channel. So it is major surgery and carrying a higher complication rate. And you can see in the low type, this is a good surgery, usually good surgical outcome with low surgeries to deal with, as it's going in a very narrow area and you don't have much space, and the bloody area with multiple organs on small space, which make the surgery difficult. One of the most debatable issues in this topic is timing, when to repair it. I will not go through political things and gender and assignment and all of this, because this is not our scope, and this is not the mission of this conference to talk about it. But we will talk scientifically. Do it early or do it late. Early as mean as they are newborn, or just wait for the puberty to do the case. We have two different team and two different fans, but the people who say they do it early, this is normalize the child and allow positive psychosocial adjustment of the child as he is as corrected immediately after birth. It will normalize him. Also, they advocate like it will relieve the parents' distress and improve their outlook toward their child. And raising the child with genital ambiguity would be extremely difficult if they are old. This is why they recommend it to be done early. Also, they advocate for early surgery because the procedures are easier, results are better, stigmatization of living with genital ambiguity is reduced. The other group who said do it after puberty question this wisdom, and informed consent is impossible with the infant. The decision for genital surgery is right of the patient. It's not right of the parents, which is there is a lot of question mark on this, but this is what they have advocate, and this is the reason why they support to do it after puberty. The ethical issues involving the parents' rights and responsibility to make decisions for their child remains still unresolved. So the wisdom is, unfortunately, there are no data on the impact of raising the child with genital ambiguity. Regardless of one's personal belief, all pros and cons of both surgery and observation must be presented to the parents without bias, and certainly the option of observation with psychology, so it is a multidisciplinary team. Consensus statement on CIH from the Lawson Pediatric Endocrine Society and European Society of Pediatric Endocrinology recommends surgery in the 2 to 6 month old range for those with high vaginal confluence, and surgery between 12 months and adolescent is not recommended. There is inadequate evidence currently in relation to the establishment of functional anatomy to abandon the practice of early separation of the vagina and the urethra as being hot. So fact one, it's clear that genital surgery doesn't cure DSD. It's known that women with CH are less satisfied, subject to whether they had undergone an operation or not. The other fact is, regardless of the location, it's best combined with the clitoplasty and in a single stage, and this allows the surgeon flexibility, which means it's more for the surgical part. Thanks God, I did from these cases in the last 12 years when I became consultant. This is my special interest, is the reconstruction of the common urogenital sinus and the mobilization genitoplasty, feminizing genitoplasty. And I reach now one of the good numbers. So I reach now almost 73 cases till now. And we have good outcome. And this is the surgical step usually we are doing. So usually we start with the clitoroplasty, labioplasty, then genoplasty. So preoperatively, it's important to ensure the patient is metabolically stable, in particular a child with CH. Bowel preparation, because you might need to use a small piece of bowel, broad spectrum of antibiotics, and they should undergo stress dose for the CH, as you know. Then we go to the next step. Historically, they do clitoris amputation. Then due to many reasons, complete reserve it. So because it have a benefit for them after puberty. Today, when performing the clitoris, so every effort is made not to only provide excellent cosmesis, but also to retain normal innervation. As you can see here, the innervation, if you cut all of these nerves, they will be a bad effect on the girl. But now if we save it and we spare it, usually they have good benefit. So then we do the reduction and we took the most of the tissue, but you keep only the head and the innervated part, which will have a good beneficial in the future. And this is one of the cases where we excise, as you can see the arrow here, we excise all the area here, and we kept only the nerves up and down and only the glands. So corporal sparing clitoroplasty also, this is one of the procedure which I don't like much, but it has very difficult steps and doesn't have good impact like the previous one. Gynecoloplasty have many techniques. I don't want to bother you with the surgical details, but just to know, like, there is a cutback and there is a flap and urogenital site mobilization, either total or partial, and we have pull through. And every one of this technique, it has a special indication according to the imaging you did before. This is one of the cases you can see in the left. This is the pre-op and this is the post-op. So you can see here the things how it corrected. And here, where is the common urogenital signs? This is what we call it common channel in the beginning of the lecture. This is the common urogenital signs. This is a common channel, and we bring it here to the front, and you can see here is the urethra and here is the genital tract. It is separated and comes to the surface of the skin like a normal girl. So giving estrogen preoperatively, it has a very nice effect because the wall will be thick. Then we go to the next step, which is a cosmetic, is a labioplasty. So the outcome, usually success should include the normal erotic sensation, lubrication, orgasm, satisfaction, and intercourse without discomfort for the child. The poor results were caused by failure to exteriorize the vagina initially or by scar formation. Normal caliber vagina must always be reached and exteriorized with current procedure. And the problem happen if this surgery done by non-expert people, failure exteriorize in the first surgery will make it very difficult and will be failed forever. This is another study widely quoted, but almost all of this patient underwent a cutback vaginoplasty because they got a problem with the stenosis. Gerhardt, which is the father of pediatric urology, looked at bibudendal evoked potential after clitoroplasty and found that good innervation is a good girl when they grow up. There was no difference in the ability to achieve an orgasm, whereas the women with CH were less satisfied with their genitalia, whether operated or not. In summary, it seems clear that single-stage early vaginoplasty will probably require secondary repair after puberty, but this should be expected because the orifice is likely to remain the size that was created. So given that there is no flow through the orifice in the childhood, in the author's experience of this study, the secondary refinements are easily performed. So we do the conclusion of this one is a recommendation of most of the people right now is to do it as early as possible, between 2 months and 6 months, and don't delay because the psychosocial impact is very bad regardless the surgical outcome, which is almost the same in both areas. Thank you very much, Dr. Nabil, for the invitation. Thank you very much for the company and for the organizing committee. And good night.
Thank you so much, Dr. Abdel Hakim, and we were honored by your share with us. Thank you, and good night. Now we'll move to our last speaker. Our last speaker will be from USA, Professor Dan Volker. Professor Dan Volker is a clinical associate, allergic disease, Department of Internal Medicine, Albert Lea, Minnesota. He's an assistant professor of medicine in Mayo Clinic College of Medicine and Sciences. Professor Dan will speak to us about the relationship between immune deficiency and the bone disease. Actually, we asked for this lecture because we had a baby in our unit who has, from the start, he was diagnosed as immune deficient newborn, and he had unexplained fracture multiple bones in his body. and he went in a severe osteopenia of prematurity. In spite, we're giving him all the precautions. We are giving good nutrition, phosphorus, vitamin D, and everything. That's why we asked for this lecture. And thank you so much, Professor Dane, for being with us. You can start sharing your screen.
Thank you. Yeah, thank you so much for the invitation to speak. And thank you all for being up. I know it's late. Where are you all at? So I really appreciate you all staying up and listening to the talk today. I'm just trying to get the share function going on. Sorry here. Okay. And you all can see my screen, correct?
You can just go to slideshow and start. Yes, it's okay.
Okay. And are you all seeing it correctly?
Yes, yes.
Yes,
Thank you. Thank you. All right. And so today we will be talking about the relationship between immunodeficiency and bone diseases. And I want to thank you again for inviting me to speak today. And so this is a little bit who I am, since we're speaking virtually and sometimes it's hard to see. So I am Dane Velker. I am currently an assistant professor of medicine in the Division of Allergic Diseases in Mayo Clinic Rochester and Mayo Clinic Health System. And so I was able to train with Megan Cooper at Washington University in St. Louis. She does a lot of studies with immune deficiency, and she's kind of one of the leading experts currently in immune deficiency. So I trained under her tutelage, and then I've continued seeing immune deficiency here at Mayo Rochester, and as well in the health system, which is a satellite of Mayo Rochester, about 40 minutes away. And so I don't have any financial disclosures to report today. And so we're going to discuss the role of the immune system in bone repair. We're going to also talk about inborn errors of immunity, and this will lead into the talk of immune deficiency. And then finally, we're going to analyze which inborn errors of immunity can affect bone diseases. So there are several of them. They are very rare, but they can happen, and we'll talk about those today. And so when we think about bone, think about the bone, think about the immune system, the skeletal system, think of a term called osteoimmunology. And so this is the relationship between the skeletal system and the immune system. So the immune system plays a role in diseases affecting bone resorption and bone formation. So this can include erosive neuropathies, osteoporosis, rheumatoid arthritis, inborn errors of immunity. And we know that inflammation is essential in the process of bone fracture healing, and inflammation precedes bone formation and remodeling in the bone fracture healing process. And in a few slides, we'll actually have a pictorial diagram about the inflammation that occurs in bone healing. And so the immune function in fracture healing. So there have been studies, and this has shown that both the innate and the adaptive immune system are involved in each of the different phases of bone repair. And so innate immune system involved in bone repair is going to be macrophages, monocytes, neutrophils, natural killer cells, and a variety of different cytokines. Tumor necrosis factor is one of those, as well as interleukin-1. So we know some cytokines that are involved in kind of immune function and fracture healing. And then we know T and B lymphocytes of the adaptive immune system are also involved in bone repair. And so when we think about these stages of fracture healing, we want to think about inflammation. So that's kind of the first process of bone fracture healing is the inflammation. So this is when you get the hematoma formation. You have inflammation with cytokines and immune cells that come in that form this hematoma, that then you get into the repair process. So this is when you have musculoskeletal stem cells, this MSC, macrophages, T and B cells, which make your soft callus cartilage, then your chondrocyte, your osteoblast, then this kind of hard callus woven bone. And then you have remodeling. So this is where your musculoskeletal stem cells come involved in play, macrophages, other cytokines, and your T and B cells as well. And so when we think about factors affecting wound healing or fracture healing, you think about, kind of a single traumatic fracture or just any type of fracture. With healthy individuals, you get acute inflammation of the bone, the inflammation comes in, you get the proliferation, and you have repair. This is kind of explains your normal wound fracture healing process. But in certain risk factors, now this is not going to apply to a lot of pediatrics, kind of the diabetics, smoking or aging, but this infection is also inborn errors of immunity, which I've added here. You can get chronic inflammation, dysregulated inflammation, and then you get kind of the abnormal proliferation repair, and you get delayed wound or fracture healing. So this is kind of the processes that we think in some of the bone fractures that we can see in patients with inborn errors of immunity. And so now we're going to transition more. We talked about a little bit about osteoimmunology. Now we're going to transition into inborn errors of immunity. And so when we think about this, we have, it's called human inborn errors immunity, or something you'll see commonly in the literature is IEI. That's the abbreviation for this. So it's a large group of disorders resulting from damaging genetic variants in both the innate and adaptive immunity. So when we think about this, there's different phenotypes, which we'll highlight in the next slide, but you can have infection, recurrent infection, and this can be bacterial, this can be viral, this can be fungal. Then you want to think about malignancy, allergy, so food allergy, atopic dermatitis, different things in that manner. Autoimmunity, where autoimmunity is going to affect the adaptive immune system, so your T and B cells, and then autoinflammation, which is going to affect your innate immune system. So every 2 years, since about, I think in the late 2000s, early 2000s, there was a report that comes about every 2 years. So there's going to be one that they just met, kind of the Committee on Immune Deficiency met here at the end of September, early October. And so we'll have another paper that's going to be coming out the end of the year to early next year. But in the 2022 report, which is our most current one, there's 485 current genetic variants recognized as inborn errors of immunity. And so while these are individually rare, the estimated worldwide population of all inborn errors of immunity is approaching about 4.8 million individuals. As our diagnosing and our recognition of the disorders become more common, we are going to look at these more. But right now, worldwide estimated is about 4.8 million individuals. And this can include syndromic diseases that we'll talk about, or just standalone genetic variants. When we think about features of inborn errors of immunity, this PIDD is primary immune deficiency disorder. So this is going to be where you have your recurrent infections. It can overlap, though, with immune dysregulation, or this PIRD, which is primary immune regulatory disorders. And then you can get systemic autoinflammatory disease. In this kind of mix, you can get atopy, so food allergy, atopic dermatitis, or eczema. And then you can have increased malignancy risk, and you can also have other bone marrow and hematopoietic issues, as we'll talk about with bone fractures and things in that manner. And so this is kind of features that can be shared with inborn errors of immunity. When we think globally of inborn errors of immunity, you want to think about immune deficiency problems, and then autoinflammatory problems as well. So those are kind of two subsets that you look at if you look at some of the phenotypes. But they often overlap because the immune system have multiple different functions. And so when we think about bone diseases and inborn errors of immunity, you want to think about osteoporosis, osteopenia, bone fractures, osteomyelitis, osteopetrosis, osteoclastogenesis, and osseous dysplasia. And so when we think about these things, when we have osteopetrosis, so this is a bone disease that causes bone to grow abnormally, and I'll actually have a photo later, and become overly dense. Overly dense bone are very brittle, and they can fracture easily. So this can be genetic variants that can lead to this. Then we have osteoclastogenesis. This is typically in this osteopetrosis type thing, but this is when you get formation of osteoclast from osteoclast precursors, and this can stimulate bone resorption. And then you have osseous dysplasia. So this is abnormal development of bone tissue, typically leading to growth failure and very short stature. So now that we've talked about different inborn errors of immunity and bone diseases, we are going to then kind of lead down the pathway of which inborn errors of immunity affect each of these different things. So inborn errors of immunity, osteoporosis, and bone fractures. And so one of the ones you most commonly see with bone fractures, especially in kind of the newborn, early onset stage of life and osteoporosis, is hyper IgE syndrome. So these are inborn errors of immunity that are frequently associated with osteoporosis and bone fractures. And so hyper-IgE syndromes are made up of several different genetic variants. Most classically is the autosomal dominant hyper-IgE or Job syndrome. And so this is going to be, that's the autosomal dominant STAT3 loss of function, which we'll talk about in the next slide. And then we have autosomal recessive hyper-IgE syndrome. So this is a group of disorders. So DOC8 is one common one. ZNF 341 is another common one. And then interleukin 6 is another common one as well. And so when we think about the autosomal dominant hyper-IgE syndrome, so this is going to be a STAT3 deficiency. So you have an autosomal dominant loss of function. You can have de novo mutations, but it's typically inherited in an autosomal dominant fashion. It's also referred to as Job syndrome. And the reason why that is because there can be a lot of boils, skin infections, and things involved. So when we think about Job syndrome or hyper-IgE syndrome, I don't like using the kind of the nomenclature names like, autosomal dominant hyper-IgE syndrome. So when we think about that, we have very distinctive facial features. So and I have a slide next that we'll look at that. So they have a broad nasal bridge. They get bacterial infection, a lot of Staph aureus infection in these individuals. They'll get boils. They can get pulmonary abscesses, pneumatocele. If you see that on X-ray or CT, that's one of the telltale signs that this may be autosomal dominant hyper-IgE syndrome. Atopic dermatitis at a very young age is very difficult to treat. Kind of mucocutaneous candidiasis, where you can get nail fungal infections, skin fungal infections. Then you get hyperextensible joints, osteoporosis, bone fractures. Scoliosis is one of the scoring criteria as well. They have retained primary dentition, and they can also have coronary and cerebral aneurysms. I do have a few patients with the STAT3 deficiency. It was actually de novo mutations in the patients that I have seen, but you can also get them familial as well. When you look at these distinctive facial features, you get this, you can get facial asymmetry on in these folks where it looks different from one side to the next, but you also want to look at the prominent forehead that you can see in these individuals. They have deep set eyes, which you can see as well. They have a very broad nasal bridge, as you can see. And then they have kind of this fleshy nasal tip as well. They can have the lower jaw that can kind of protrude out, so prognathism as well. And usually they have kind of rough facial features with prominent pores as well, as you can see in some of these individuals. So this was from a paper in 1999 in New England Journal of Medicine, but it still kind of holds true in the patients that I've seen in my clinic. And so other hyper-IgE syndrome associated with bone diseases. So we want to think about interleukin 6 signal transducer deficiency. And so this is going to be characterized by recurrent skin infections, bacterial infections, boils, again, atopic dermatitis, pulmonary abscesses, pneumatoceles can come into play. Again, bone fractures, scoliosis, retained primary detention. Can be complete or partial deficiency. Usually complete deficiency it can be fatal near term or very early onset death in those individuals in a lot of the complete deficiencies, but partial, there can be an autosomal dominant or autosomal recessive inheritance for those patients. And then when you think about one of the classic autosomal recessive hyper-IgE syndromes, there is the ZNF 341 deficiency. So this is going to be a phenocopy of autosomal dominant hyper-IgE syndrome. So the reason why that is ZNF 341 is actually a transcription factor that binds the promoter region of STAT3. Well, STAT3, as we just mentioned, was involved in the autosomal dominant hyper-IgE syndrome. And so that's why it's a very similar phenocopy of that. So it's autosomal recessive inheritance, early onset atopic dermatitis. You can get a mild facial dysmorphism similar to the autosomal dominant hyper-IgE syndrome. You can get bacterial skin infections, abscesses, recurrent bacterial respiratory infections, pulmonary abscesses, pneumatoceles, mucocutaneous candidiasis, hyperextensible joints, bone fractures, and primary retained teeth. So then other ones, hyper-IgE syndrome, so ERBIN deficiency, so you got autosomal dominant genetic variant of this ERBB2IP gene, recurrent respiratory infections, susceptibility to Staph aureus, atopic dermatitis, hyperextensible joints, scoliosis, and arterial dilation. And then you have Lewy-Dietz syndrome, which is a deficiency in transforming growth factor beta receptor. It can autosomal dominant in either receptor 1 or receptor 2. Again, recurrent respiratory infections, atopic dermatitis. This one, you have more food allergies than the others, hyperextensible joints, scoliosis, retention of primary teeth, and also aortic aneurysms in this condition. So now that we've talked about osteoporosis, bone fractures, now we're going to talk about inborn autoimmunity associated with osteopenia. And one that has been noticed is JAGN1 deficiency. So JAGN1 actually participates in the secretory pathway of neutrophils, and it's critical for differentiation and maintenance of human neutrophils. So JAGN1 deficiency, it's an autosomal recessive variant. It's one of the causes of severe congenital neutropenia. So if you have young baby or even young childhood that has low neutrophils, you want to think of JAGN1. Especially if they have osteopenia, you want to think of this. So JAGN1, so it's an endoplasmic reticulum resident protein, has function in the early secretory pathway of neutrophils and is critical for the differentiation of those neutrophils. Then, in addition to myeloid maturation risk, it's associated with osteopenia. And so that is the one that is associated with osteopenia. So now we're going to transition to osteomyelitis. Sorry. And so now we're going to talk about inborn autoimmunity associated with osteomyelitis. So there's two of these, and we'll talk about it in the next two slides. So the first one is going to be called chronic recurrent multifocal osteomyelitis and congenital dyserythropoietic anemia, or Majeed syndrome. This was actually found in a few families in Jordan, and it has been found in other families as well, but some of the initial cases were a couple of families in Jordan. So the genetic defect is in LPIN2. This LPIN2 encodes for a protein called lipin-2. And so lipin-2 has functions in processing of fats or lipid metabolism, but it is also important in bone remodeling, and it's important for bone remodeling, so that's why it can be associated with osteomyelitis. It's also important in the NLRP3 inflammasome, so it's a very important regulating inflammation. So if you don't have this, you can kind of get unfiltered inflammasome activity. And so in this is the autosomal recessive disease where you get multi-system inflammatory symptoms. We get chronic sterile multifocal osteomyelitis, you get recurrent bone pain, you get recurrent fever, you get a failure to thrive. You can have cutaneous inflammatory disorders. One of those is neutrophilic dermatoses. And then you can get a transfusion-dependent anemia as well. And so this is it's very rare. It's documented only a few times in the literature, but this is something that can occur. So if you have someone who's very young who has osteomyelitis, especially if it's sterile, meaning there's no known bacteria or other organism found or fungal, you want to think about this. Also, another disorder, it's called deficiency of interleukin-1 receptor antagonist, DRIA. So this is a genetic defect in the interleukin-1 receptor antagonist. And so it's autosomal recessive, as mutations in this interleukin-1 receptor allow unopposed action. So you get neonatal onset of sterile multifocal osteomyelitis. So multiple different bones having this infection, but it's sterile. There's no bacteria found. Periostitis, which is basically inflammation of the periosteum, which is the connective tissue that surrounds bone, and then pustulosis on the skin. So we move from osteomyelitis. Now we're going to think about osteopetrosis and osteoclastogenesis. So this is going to be highlighted. There's not a lot of recurrent infections in these disorders, but this can be an inborn error of immunity that can cause these things. And so osteopetrosis, as we've discussed, is a bone disease. It causes bone to grow abnormally and become overly dense. Overly dense bone is very brittle, can fracture easily. So there's several different genetic variants, and I'm not sure what genetic variant in the pediatric patient you all described earlier, if that was found or if it's tested. But when you think about these are infantile onset, and some of the disorders associated here are CLCN7, where you have hypocalcemia and some neurologic features. Then you have SNX10, which has visual impairment, OSTM1, hypocalcemia, and also neurologic features. And then other ones that are kind of unique, TCIRG1, hypocalcemia. I talked about TNF in bone fracture healing and bone remodeling, and this is where some of the tumor necrosis factor comes into play. And if you have tumor necrosis factor stimulating factor 11, that's where you get the severe growth restriction in addition to the osteopetrosis. So when we think about osteopetrosis, you have the healthy bones, thickness and density, and then you got this infantile onset, increased bone and thickness and density there. So now we're going to transition just a few more slides here. I appreciate y'all being attentive throughout this process. I know it's a lot of information. If there's any questions, my email will be on the last slide. Please feel to reach out if you guys ever have any questions about these disorders. They're rare, they're hard to find, but when they are found, they can make a big impact if we diagnose them at an early age. And so now we're going to talk about inborn errors of immunity associated with immunoosseous dysplasia. And so these are going to be come into play where you have abnormal bone, basically abnormal bone formation. And so cartilage hair hypoplasia is one of the more common ones. And this is one that has immune deficiency. It can vary depending on the severity of the genetic defect and where it's at. And so you can have a severe combined immune deficient where they have a lot of infection from a very early age to normal. On the T cell side, and you can have impaired lymphocyte proliferation. You can also have the B cells are typically normal. Immunoglobulins can be normal or reduced, and the specific antibody titers can be very low reduced as well. You get short-lived dwarfism, metaphyseal dysostosis. You get sparse hair, bone marrow failure, autoimmunity, susceptibility lymphoma, and other cancers. You get neuronal dysplasia of the intestines. So this one is pretty stark that you'll see. They have abnormal hair, and one that they have very short limb dwarfism, and one you want to recognize at an early age. And then there's Schmecki immunoosseous dysplasia. And this is short stature, spondyloepithelial dysplasia, intrauterine growth retardation, nephropathy, so kidney disease, bacterial, viral, fungal infections may present as SCID as well, and you have bone marrow failure. And then you have MYSM1 deficiency. Again, you're going to have short stature, recurrent infections, congenital bone marrow failure, myelodysplasia, immunodeficiency, mostly of the B cells and the granulocytes, less of the T cells, but can happen, skeletal anomalies, cataracts, and then developmental delay, and then MLPD1 deficiency, Rothman syndrome, similar recurrent bacterial infections, lymphadenopathy, dysplasia of the spondyloepithelium, extreme growth restriction in these, retinal dystrophy, which is a little bit different than the above three, facial dysmorphism, and may present with microcephaly and short stature. And then the last one is aminoskeletal dysplasia with neurodevelopmental abnormalities, or EXTL3 deficiency. So all of these are autosomal recessive, if you want to think about, and you have T cells are decreased, normal B cells, your immunoglobulins are decreased to normal, you have short stature, cervical spinal stenosis, neurodevelopmental impairment, eosinophilia, which is unique compared to the ones above, and may have early infant mortality as well. And so this is a kind of a paper that came out in 2022 that goes by the phenotypes and classifies it based off these things. So if you look at this paper, it can help kind of phenotype your underlying inborn error of immunity if you see this in your practice. And so overall, you want to think the immune system is very important in bone formation and bone fracture healing. Inborn errors of immunity can involve different phenotypes hallmarked by infection, malignancy, allergy, autoimmunity, and autoinflammation. And in patients with early onset recurrent infections or growth restriction, or sterile osteomyelitis, you want to consider underlying inborn error of immunity. If there is inborn error of immunity suspected, you want to refer to an immunologist. Locally, I don't know how many immunologists are there where you all at, but immunology or also a clinical geneticist to consider testing. There's several different inborn error of immunity lab panels out there. You can also do whole exome or whole genome sequencing. So there are genetic testing available to look for these things as well. So just want to thank you all for your time today. Again, if there's any questions, please feel free to reach out to me at any time. More than happy to answer if there's hard or difficult cases. I just want to say thank you again for inviting me and for your attention today.
Thank you so much, Professor Tin, and for sure, inshallah, we'll send you through our consultation system we have many cases to take your opinion. We can mention your name when we will do a micro consult on the system, inshallah.
Yeah,
So
it'd be great. And I work with Avni Joshi, who's one of our other immunodeficiency experts, very closely. So her and I see most of the immune deficient cases here. So we're always more than happy to reach out and help as much as we can.
Okay, thank you so much, and we're honored by having you with us. Thank you so
Awesome.
much.
Thank you all.
Thank you. So we'll move to our last speaker, will be Dr. Manab Najjar. Dr. Manab Najjar is a consultant of ophthalmology, and he will speak to us about one of the, I don't know if we will like this, can a pediatrician be ophthalmologist? No.
Yeah, Doctor. No, this is the question. It's very interesting questions, and it can be a pediatrician.
A pediatrician can do everything.
Yes, I agree with you. With very small few tricks, he can be, at least he can correctly and precisely, he can refer a patient to ophthalmologist, which is usually can be missed. First of all, I'm honored to be with you, and this is the last lecture. I know you are tired. I will be very short and precise, as much as I can. The answer is can be yes or no, but let's go ahead and move. Improving neonatal cares, resulting increase in survival of preterms, increasing in the long-term medical sequelae, and also it helps with the mortality also. And the preterms are increasing risk of chronic illness like cerebral palsy, asthma, and motor skills defects. But also the preterm, even if it's went normally away from retinopathy of prematurity, they have 3 times more likely to have a poor vision than those born at term. Also, they can be associated with many refractive errors, strabismus, cerebral visual impairments, color vision defects and visual field defect comparing to the normal preterm. So I will not talk a lot about I know it's a last lectures. I will talk just simply that most of the premature babies, they have very shorter axial length comparing to the full term. Okay, and will develop that these babies usually they have hypermetropia as it's logically when they have a short eye, it will have hypermetropia. But the problem with these patients, usually when they are developing in the nursery, I'm usually referring to referrals that they are telling me that the cornea is hazy. Usually the cornea is normally hazy. The corneal haziness is normal until 26 weeks of gestational age. Usually the cornea, you will feel it hazy, and it will become decreased significantly after 32 weeks and achieves full clarity at 40 weeks of age. Also, other questions I am receiving, is this the eye is small, the cornea is small? Usually there is a very simple equation. In a premature baby, the corneal diameter, we can check it by any neonatologist, no need for ophthalmologist, and by using this equation, that the corneal diameter by any ruler, simple ruler, equal 14 per 10,000 in weight in gram plus 6.3. This equation gives me the way that I can know if it's within the range according to the prematurity or not. For example, if I have a baby, birth weight was, now his weight is 1,000 gram. So when I will multiply by 14 per 10,000, it will equal 1.4 plus 6.3, it's 7.4. So if the corneal diameter is 7.4 or more, so it is a normal. So this is not a microcornea, because sometimes they are referring a patient that the baby has a microcornea. I will use this equation to correlate between the weight, the birth weight of the baby, or the weight, actual weight, plus the correlated the corneal diameter. The haziness also is very important. As I said, 10% of the premature infant are noted to have a corneal haze, so it is a normal phenomena. The corneal haze is up, as I said, to 26 weeks, significantly decreasing by 32 weeks, and normally it is transparent by 40 weeks. The birth weight is the most important predictor for the corneal haze. Lower the birth weight is more corneal haze. So if I have a corneal haze, I will not diagnose the patient as a congenital glaucoma or corneal scarring, but I have to wait little bit after 32 to 34 weeks, and then you will reevaluate again. Other questions here. There is another case I want just to show you. Yeah. What's called the ophthalmos. Ophthalmos, if there's a corneal haze associated with the enlargement of the cornea, and this is one of the striking feature of congenital glaucoma. So when you are seeing a large cornea, large globe comparing to the other eyes, this is most probably with a haziness. This most probably is a congenital glaucoma, and usually males are more common than females, and usually the unilateral more common than bilateral. Okay. Refractive state, as said, because the globe is small, so logically it should the baby hypermetropic. But in a premature baby, paradoxically, there is myopia. It's the most common features in the baby. If you do refractive, for example, by using retinoscope, I will see it is a myopia instead of hypermetropia in normal full term. Why? Because the lens in the premature baby is still large, high aspheric power, high, more refractive power, with tending to shift the globe into the myopic states, and the corneal curvature is very high. These two reasons makes the globes in the premature are more myopic than in a normal full term, which is a slightly hypermetropic. But with time is stabilized. Now, what about the strabismus? Few words, strabismus or misalignment. Usually in premature babies, there's increasing prevalence of strabismus than comparing to the normal terms. Usually esotropia and exotropia is 1-to-1. Esotropia, it means that ESO, shifting the globe inward. Okay. Exo is shifting the globe outward. So as in the first above image, usually in premature, the percentage is 50% of the babies can be esotropic, can be exotropic, while in full-term babies, usually esotropic is almost 3-to-1. 60% of the patient is esotropic, and 30% of the full-term babies will develop, if they have a problem, will develop exotropia. It means the shift the globing outside. So this is increasing in the patient of the ROP, increasing of the more premature, low birth weight. They are more prone to develop refractive error later in life. So overall, strabismus is 5 times more common in preterm more than those born at term. So let's talk about the visual acuity. Always I'm receiving this message. Is the baby seeing or not? It's very hard to see, very hard to tell, but we have a few tricks that we have to do, and even pediatrician and neonatologist he can do. He is trying to measure the visual acuity, and at least he has a hint about the vision of the baby, if the baby is responding to the light or not. And the most important definitive measurement of visual acuity is evoked visual potentials, which needs electrodes and needs specific machines and specific personnel, which is not usually available in any center. So we have 3 methods. If it's available, we can easily assist. The babies or premature babies are more prone to have to look to the patterns than the pictures, especially in the first few months of life. So the most important here is what's called a preferential looking test, bringing a large board. This is a gray board. It can be done even in the clinic with the small 2 round circles inside. One we have just what's called a plain circle, and the other one with the horizontal or vertical black and white dots. So the babies usually they like the patterns more than the pictures. So, and let the baby to sit in front of the mother looking at this pattern. Usually he will look to the direction of the pattern. So for example, if this is if the distance between the black and dots is wide, so this is mean the vision, for example, 2200 or 0.1 or 1 or 10%. For example, then I will change this one. I'll put it in the other side, in the here where there is a plane, and then I will check the vision. Automatically, if he can see, he will look to the area where is the board with black and white dots. And for example, with reducing the number and reducing the distance between these vertical black and white roads, this will improve the vision for him, and see if the baby is looking to the right and left according where you are putting the board. We can empirically assessing the vision of the baby. We have also what's called the vertical optokinetic nystagmus drum. It is a drum also using the theory of patterns and rotating this drum upwards or downwards. Involuntary, the baby's eyes is moving in the same directions and then returning back. And when we are reducing the size of these roads or these columns, black and whites, the vision is, we can check more and more smaller roads, and then it means it gives me a clue about the vision of this baby. Optokinetic, what's called the last one, is a visual evoked response. This is, we need a specific equipment like a band, electrode bands, and this is, it is measures the stimulus of the occipital cortex in the brain to the stimuli, to electrical stimuli. So we're putting the band with electrodes in the front, head in the back over the occipital cortex, and then asking the baby to look for example, TV or monitor here with a visual stimuli, and see if the optic nerve is responding, if the occipital cortex is responding, and then we can get a clue about the vision. Usually using 3 methods, it gives me a full vision. For example, 20 over 20. For example, in using optokinesis nystagmus drum, it will achieve 20/20, and the baby can assist exactly at almost 1.5 years. Sorry, 2.5 years. Here, in cases of forced preferential, this test, until 1.5 years, we can see the vision. He can reach it 20/20 vision. Visual evoked response, it's earlier. At 6 months, we can give a clue about if the baby, he can see 20/20. We have also another clue about this. For example, at 1 month of gestation, very soon after birth, the baby can fixate and follow a light source. If you are putting a strong light source, okay, he can fixate over it and he can follow it. But the fixation can be central and steady, and it can maintain. It means steady, there's no nystagmus, maintained, there's no squint, and central, so there's no squint. This can be almost at the 1 month. At 3 months, binocular vision starting to develop. So it's very critical period that we have no obstruction to the view, therefore no cataract by 3 months, because if this happens, then the patient, he will lack development of binocular vision and stereopsis. 6 months, he can reach it out accurately for toys. If you put a toy away from him, he can reach it. 9 months, he can look for a hidden toys. 2 years, picture matching, and 2 and 5 years, he can use a normal adult Snellen chart. Let's talk a little bit about the pupillary light reflex. It's very important, sensitive reflex. It's not equivalent to visual ability, but it is presents indicate the intact afferent visual defect from the optic nerve, for example, to the level of the brachium of the superior colliculus and the efferent pathway. This is working nice? Is the neurological system, brainstem is working or not? So this is presented the premature babies from 29 to 31 weeks, but be aware that if you are putting a strong light on the eye, you will not expect very strong constriction. This is suggestive that the neurological pathway is intact, because the pupils of the premature babies, because of the poor sympathetic tone, is very narrow. So therefore, you need to use, for example, a magnifying loupe, put it in front of the eye, then orient a strong light and see if the pupil sluggishly is responding, sluggishly is constricting. So it means that the pupillary light response is normal. So most probably the optic nerve, the anterior part of the optic tract is intact and until reaching the brainstem, but is not responding to the visual acuity, is not related to visual acuity in these cases. So there's a very simple method called the central steady maintains. Usually the central steady maintaining the looking at the object usually develops in the new full-term babies at 1 month. It's done by fixating a target like at a 40 centimeter from the baby. Bring a very brilliant, for example, toy, put it and see the reflexes. If it's central, the light reflects in both eyes central, so it means that there is no strabismus. But if it's one eye central and the other eye, the light reflex is shifted either outward or inward, so it is most probably squint. And if it's unsteady, steady is S, it means steady. Steady or unsteady, it means there is an nystagmus. If there's unsteady, it means there is an nystagmus. And if he's following alignment, if, for example, if asking the baby to look to the right, you move the the target to the right or to the left, and the baby is following these targets, so usually he has a good vision. If he missed the target, most probably he will have a poor vision. So usually we have some empirical just measurement. If the reflex is central, steady, and maintains, usually the vision is good until 20/30 or 6/9. If is central, steady, and not maintained, it's not following the subject, usually the vision is poor from 6/36 to 6/60. If he has a central fixation but unsteady with an nystagmus moving of the eye, usually the vision is poor. So contrast sensitivity is very important. Usually it is reducing in babies premature comparing to the full mature babies. And visual fields, usually it's one of the side effects, as we said yesterday, of using of the laser in the treatment of active acute ROPs. Therefore, this is the visual field. It's one of the common side effects after laser therapy. Color vision, they found that the babies who underwent laser treatment will have some color vision defect, that especially in the blue-yellow color defect, and this is very common, which is more than 200 times the rates in the general adult population. So the take-home message, what we can see, that extremely low birth weight are 3 times more likely to have a 660 vision and 4 times more to have refractive errors, and 5 times more to have strabismus. So we have to wear that premature is a premature for life. We have to follow these babies for life. Thank you very much, and I hope thank you, Dr. Nabil, and organizing for this excellent symposium, and I'm really honored to be with you today, and I'm ready for any questions.
Thank you so much, Dr. Manar, and I hope that all the attendees have a benefit from this valuable lectures. With this, we will close our symposium for this year. It was a very successful symposium, and I learned a lot from the valuable lectures. I'm thanking all the speakers, all the organizing committee, Mr. Ala and his team. Thank you for you all, and I hope, inshallah, that we will meet next year in our 8th symposium. And I thank all the attendees who stayed with us till now over the 3 days. And I hope that anyone will have a problem in the CME hours or in a certificate or something like this, he can contact us or contact Mr. Ala, and we will solve it. Thank you so much for all, and Assalamu alaikum wa rahmatullahi wa barakatuh. See you, inshallah, next year. Thank you.
شكرا دكتور نبيل. شكرا.
شكرا. السلام عليكم.